Hello. Welcome. Thank you so much for being here. We're so glad you decided to join us for our 2020 virtual workshop, Change Through Community. For those of you who don't know me, I'm Elizabeth Feaster, the founder and executive director of T1 International. Back in 2013, T1 International started out as kind of a one-woman band and a fully 100% volunteer effort, dedicated to pharma-free advocacy that would achieve long-term solutions to improve the lives of people with diabetes around the world. Last year, we expanded, bringing Alison Bailey onto our team and some part-time staff in the UK as we continued to build things from the ground up. We've undergone bigger, significant changes recently. In the last 2 months, thanks to seed funding from Arnold Ventures, we've added 5 new team members to our US team, all of whom have contributed significantly to this weekend's event. This is hugely exciting for us, and it means we can better support our chapters and advocates and hopefully build sustainability as an organization, because we know that a lot of change is still needed and that it's going to continue to be a long, hard fight to get to a reality where no one struggles to afford it or access their insulin or supplies. This expansion of our team has also fundamentally changed the way we operate and continues to require thoughtful planning to ensure we're building an organization that lives up to our values and keeps patients at the center of all that we do. We will keep learning and growing together and finding the best ways to do that. Community has been crucial during this time of COVID and of general upheaval throughout the USA. I have seen firsthand how the diabetes community has kept each other going, and I imagine so many of us have benefited from being part of communities that support us during hard times. We're so proud of our T1 International Insulin for All community and the resilience of our chapters, advocates, and supporters who keep pushing for better lives for people with diabetes. Despite challenges, our chapters, leads, and other advocates keep going and keep standing up for themselves and others. It's truly amazing to behold. The insulin price crisis is still in the national spotlight, and significant state legislation has been passed, all thanks to the efforts of patient advocates and their allies. These next 2 days of workshops are intended to be a place to educate and inform, and to be the start of discussions around the many issues that intersect with diabetes and the access and affordability crisis in the USA and beyond. We hope you find it informative, thought-provoking, and inspiring. Some parts of it might make you upset or angry, rightfully so. But as you'll hear from our speakers, Nicole and Jazmine, those feelings can be powerful if they're channeled towards action. We can't thank you enough for being here and being part of this movement that's made up of powerful patients in many various perspectives. This video that we're about to share, which I'm very, very excited to share with you, was illustrated and animated for us by Janina Gaudin, also known as Miss Diabetes, and it sends the message better than I can. I was so grateful to work with Janina on this project as she brought the vision to life. As the video shares, we have and we will create change through community. I truly believe that. So have a look, and thanks for being part of this weekend and this movement with us.
Thank you so much, Liz, for welcoming all of us to this year's workshop, and to Janine for that beautiful video. Good evening, afternoon, or morning to all of you, and thank you very much for joining us today for day one of the 2020 T1 International Insulin for All Workshop. My name is Eli Gerber, my pronouns are he, him, his, and I'm the policy manager for T1 International USA. We're excited to have all of you with us today for an excellent day of programming to learn more about the Insulin for All fight. We're going to cover a lot of topics, and we're excited to welcome so many new advocates who are able to join us at this year's virtual workshop. Before we dive in, a few quick Zoom housekeeping notes for us to review. For today's sessions, unless otherwise noted, we will not be using the chat feature. On your screen, you'll see the live Q&A button, which is where you can enter your questions for those sessions hosting a Q&A. Questions will only be seen by our T1I team, and we'll do our best to address them as we are able. We're an open, welcoming community, and we ask that all participants are respectful and kind with any questions they ask our speakers today. We also have an option for live captioning. In the upper left-hand corner of your screen, you'll see a red Live button and a drop-down menu that says View Stream on Custom Live Streaming Service. This will open a live transcript of today's sessions. And to kick off those sessions, we're going to start the day with a Global Perspectives panel moderated by T1 International Executive Director, Elizabeth Feaster. Liz, the floor is yours.
Hello again. Thanks so much. And thanks again for joining and being here with us. It's my honor to be here with 5 advocates from 5 countries around the world, and they're going to be sharing a bit about life with diabetes in their country and the advocacy they're carrying out on the ground. It's going to be really exciting to hear about this and to hear about what's going on in their country. I'll introduce each speaker before they share, and then the panelists will also be taking questions from the audience at the end if we have time. So feel free to enter questions in the Q&A box, as Eli said, and then we'll answer as many questions as we can as time allows. So I'm going to introduce each speaker one by one before they chat so we can make sure that we know who's sharing. And we're going to kick it off with Sana Ajmal from Pakistan, who's doing some amazing work there. So please take it away, Sana, and then I'll introduce the next speaker after you've shared your updates.
Thank you so much, Les, for inviting me to present here today. Hello, everyone. My name is Sana. I'm from Pakistan. I've been living with type 1 diabetes since 1998. After my interaction with the young leaders from the world over at IDF in 2011 and later on at many other forums, I realized how big and complicated the problem of access to good care was. And it wasn't just the people in developing countries facing it, but even those living in developed high-income countries were at risk. So over these years, I've known numerous stories where people have lost their lives because they couldn't access good care, and it just saddens me deeply. So Meethi Zindagi, of which I'm the founder and executive director, was founded around the same time as Type 1 International, and the advocacy efforts of Type 1 International propelled us actually to initiate an on-ground support program for children with diabetes in Pakistan. I cannot appreciate Type 1 International enough for what the organization is doing for the cause worldwide. We realized that while we advocate for change, we could just not leave these vulnerable children unsupported. So I'm very proud to say that we're the first people's organization, when you may call it the patients organization. We're the first people's organization in Pakistan who have taken up insulin support for deserving children as a nationwide initiative. And as I go through my talk, it will be apparent how the model addresses many of the access problems simultaneously, and how Type 1 International has actually helped us develop this model through its advocacy. So I'm going to tell you a few stories. And before I begin, I want to disclose that we have public media sharing consent for all of these stories. And I have no conflict of interest to declare. So here, if you see this first picture, this is of Laiba. Laiba is 12 years old, and she has been living with type 1 diabetes since 2017. Can we go to the next slide, Liz? I would like to start with Dime. So Dime, if you see here, Dime, his father is a security guard with a monthly income of $100 per month. Dime was too young to be able to manage on premixed insulins, which requires a lot of regularity in lifestyle, and he's only 18 months old. The government support provided to everyone in Pakistan is generally pre-mixed 70-30, and there are very few hospitals who will offer free mixing regular in NPH. Analogs are too expensive to afford, and it was difficult to manage with human insulins for this child too, though they are cheaper, but he just could not manage on those. He was too young. Not to talk about the blood sugar checking needs that the blood sugar checking strips that needs to be done, and all those needles and accessories one needs. So distressed, Daim's mom reached out to us. He's receiving support from Meet Zindagi since 2018. The government definitely needs to incorporate better coverage, and also all the other support organizations really need to incorporate better coverage. What we are doing for him is that the insulin that he needs is provided to him as per his requirements. Can we go to the next slide? So the second issue that we realized was very commonplace was the long waiting lines. Meet Neha. Her father is a laborer, which means that he, at his best, can get $6 a day for a day's work. There's no work half of the days. His mother works as a support staff at a school, and the family earns a total of $200 each month to feed a family of 6 members, out of which Neha also has type 1 diabetes. So government support, although available for the kind of insulin Neha uses, was difficult to access. The waiting times at a government hospital to get that free insulin can be exorbitant, and it may mean loss of work. Many a times, they also find that it was not always at regular intervals that insulin would be available at the hospital, which simply meant that they would have to return for it the next day and further loss of work. Now, diabetes is not a temporary condition where you can just go through the trouble for some time and hope for a cure and better conditions later. So again, looking for options, their doctor directed them to us, and she has been receiving support from Meet Zindagi as well at her home. So we deliver her insulin to her home so that her parents do not have to miss work days. She does not have to miss schools, and regularity is ensured. Next, please. So meet Khadija. Many a times there are such long travel distances involved that people actually find so much trouble accessing the basic care that they need. Khadija was born with many complications, including a dysfunctional pancreas. She lived with her mother in a mountaintop house, which was a 2-hour hike from the nearest medical dispensary. Her father worked in a city which was a travel distance of 6 hours from her home. This child needed 1 unit of basal insulin every day, 1 unit only. The government could not provide that, and the parents could not afford that. The child used to go severely low with all other insulins. So let's not even go to the checking requirements. The 1 unit insulin, which hardly went 1 pen every month. Her father needed to take that 1 insulin pen and some test boxes to the home on monthly visits. This little angel was registered with us for support for a short 2 months period, but passed away after an epileptic seizure at the age of 5 months. The mother could not get her to the dispensary on time for being taken care of. So she was a very sad story, but the travel distances involved sometimes are just unmanageable. And we really need to think about models where people can actually be supported where they are. Next, please. So meet Adil. Adil was diagnosed with type 1 diabetes in 2005. And once diagnosed, he was told by the school admin that he cannot come to school due to his condition. Parents were not eager to send him either. They were both completely uneducated themselves too. So once we started supporting him with insulin, it was just not important for us to ensure that his health is being looked after. We also wanted to ensure that he has a productive future, because education is always helpful in acquiring decent work. 22.8 million children in our country aged 5 to 16 are not attending school, according to UNICEF. Adil was encouraged to join school after being registered in the insulin support program, which is one of the prerequisites of being enrolled in our program, which he did. So this was also a very positive push in his life, not just towards his health, but also towards his future productivity. Next, please. So meet Hassan. Hassan left school because of financial issues his parents were facing while trying to afford his medical expenses. Hassan had developed complications early on due to his condition and found us very late. He was supported for his medicinal expenses for a year before he passed away due to the complications. So finding the right platform at the right time, timely diagnosis, all of these things are again very much important when it comes to accessing the right kind of care. However, we lost him after a year. Hassan had joined back school because of his complications. He had left school early on. He was bullied at school due to his condition, but he joined back school after getting peer support and insulin from the organization. Next, please. So meet Abdullah. He's on our insulin support program too. This bright soul aspires to become the next Wasim Akram, and I hope many of you would know Wasim Akram. He's a cricketer from Pakistan who is a world record holder and had type 1 diabetes. We would be supporting him till he turns 18, or if he continues his education till the age of 21. His future can be as bright as his smile, only if his hand is held and someone actually helps him go through this difficult time in his life. So next, please. So these stories talk about 4 major issues. One is the affordability problem, the second, and the flexibility of treatment choices, the access to test strips and needles, and not just insulin. So it's not just to make them live, it's also to help them live a good life. The second is the long lines that one has to wait for for accessing free government support, causing loss of a day of work. The third is the availability of insulin at regular intervals may not be assured, which can result in rationing and further loss of work days. And the fourth is the question mark on the future. So thinking about all these 4 problems, we decided that when we support people with diabetes, because we just could not leave them alone, our Promise of Insulin program, can we go on the next slide? So once a child is registered with us, he or she may be from anywhere in Pakistan where a cold chain maintained courier service can reach. We support the child with all their medicinal needs till the time they reach the age of 18 years or 21 years in the case they pursue higher education. The support package, which includes insulin, test strips, and needles, is delivered to their doorstep at their regular monthly intervals. So they don't need to waste time and money on travel to wait in lines, and after due diligence by a committee, the child can be provided with analog insulins too. As a prerequisite, we require the child to join school so that there can be some assurance of a brighter future in order for them to be able to support themselves as adults. Now, this is the model that has worked really well for children in Pakistan. One of our supported children has just graduated as an engineer, and others are being able to focus more on their health and education now. Next, please.
Anna, I am so sorry to interrupt, but I'm afraid that we need to have a moment for the next panelists to begin their presentation.
Perfect. So I'm just ending up. And on this, you can get it from the nearest pharmacy. Type 1 International really helped us to train our advocates, develop our key messages, and learn from case studies to develop effective support models and work on a step-by-step approach to make this a reality in Pakistan. Next. Yeah, I'm done. This is the last slide. So I just strongly believe that building a solution for the advocacy puzzle is always possible when you look at the right ways and actually try solving problems one by one. So again, thank you so much.
Thank you so much, Sana, and sorry about the time, but it's really, really important to hear about the various struggles and challenges, as well as, you know, it's wonderful that you're able to provide direct support and to, you know, focus on advocacy as well. And we're really, really grateful for all the work that you're doing and thankful for that. So thank you. And hopefully we'll have some time for questions at the end. Thank you again, Sana. I'm going to quickly transition to Cyrine Farhat in Lebanon. Lebanon has obviously gone through some difficulties, particularly recently, and Cyrine's doing some wonderful advocacy there. So I'll hand it over to you now.
Hi, everyone. It's first it's a pleasure to be here and be on board this amazing workshop. And I have to first say that Lebanon has been going through really tough situations, but I believe that through advocacy, through community, we are able to help as many people as possible. I have personally been living with type 1 diabetes for the past 13 years, and I have kind of wished to work with community because I personally thought that the more we educate people on their rights, the more we empower. So this is where the story begins. Can I have the next slide, please? So basically, I have to start with the fact that Lebanon has had over the past 2 years problems with lack of access to insulin, and before that we had kind of a lack of diabetes awareness, a lack of awareness to people's rights, to their, like, the right of access to their medication. So basically that's when I crossed paths with T1 International, and I saw the kind of advocacy they were providing, and I thought we need that. How can we do that here? And I reached out personally to Elizabeth. I was like, how can we do that here? I want to help people here. That's how Positive on Glucose started. It was something, I really wanted people to be positive on their glucose. I wanted to give kind of mental health support, and I wanted people to feel like there is a community of diabetics supporting diabetics, and together we can fight for our rights and get what is naturally ours. So basically the result was a growing patient-led community of people in Lebanon and the region. I've met so many amazing diabetics in the region too. So that has been basically the most amazing thing that came out of going with T1 International. Of course, I personally received the advocacy training, and that empowered me to know exactly where to start, how to kind of decide on the goals. Like we figured out that we needed first to raise awareness, that people needed to know that, hey, wait, we have rights. And there we can start. And I think it was the perfect time to start because fast forward to now, we are among a crisis. And I think if that community hadn't been built then, we would not be able now to respond to everything that has been happening in Lebanon. Next slide, please. So basically, there is a kind of alarming situation for people living with diabetes, me included. I personally feel the pressure of having diabetes in Lebanon right now with everything going on. As some of you know, we had a revolution in October 2019, and it kind of ignited the collapse of our economy. We have a hyperinflation, we have a devaluation of the currency, and kind of the government has been, we don't have a government to begin with, it's absent. So basically, it's a really awful situation. People don't have access to their money, hence people don't have access to buying their basic medication and their insulin needs. Plus, there are things that have been running out of the market over the past period. So this all of it together urged us to kind of act. It's like a small patient-led group with minimal resources. I had to go back and forth with T1 International, kind of ask for advice, like what should we do, where should we start? Because it was a very tricky situation. So here's what we've done. Next slide, please. So basically, because of it all started with also the COVID situation, the kind of problem escalated from there, and we started to raise our voice. We reached out to media outlets, we reached out to governmental figures, we started speaking about the problem. We were like, hey, listen, we have diabetes, we have type 1, insulin is air to us, like it's life support. It's not something we can choose to live without or substitute with something else. We started speaking about it and like making a big deal out of it. And to say the least, not a lot of people like that, but we had to speak up because that is our right, and we have to kind of live with the security that we have insulin. So that kind of worked. And then let's say the Beirut explosions happened. I think a lot of people heard about that. And part of the explosion that hit the port was kind of places where they stored medication. So that kind of also led to a bigger issue. Now we can't have access to our money to buy medication, and we don't have medication. So we had to improvise, we had to act quick. We realized that with 300,000 people displaced, with no refrigerators, with nothing, with no shelter, we had to kind of provide their insulin and their medication needs. And here we were not just looking at people with type 1, we were looking at people with diabetes in general, because everyone needed their medication. So again, here's what we did. Next slide, please. we kind of just made, we joined efforts, Positive on Glucose, my platform, joint efforts with 2 other initiative platforms on social media, Noor and Nadine from 2 Instagram accounts, and we kind of said, okay, what should we do to make insulin and diabetes medication accessible? Here is where the community kind of all came together from all over, honestly, the world, all over the GCC region, the Arab region. People were just like, what do you need? We'll just send them over. What do you need? We'll just help you. And we kind of made this Instagram page where we told people what we were doing, and we asked people to reach out to us, and we were like, okay, we're gonna try to give you your medication. Next slide, please. We started teaming up with so many people who are part of the diabetes community, again, in the Arab region. We started talking about it on platforms, we started raising funds, we started gathering medication, and we basically were able to help so many people, but we had to kind of like verify the cases, make sure who needs what first, because so many people needed medication, but we needed to kind of reach out to the most vulnerable. So next slide, please. We started making sure like we had prescriptions to say what they need, how much they need per month. We tried to validate the information as much as we could. We did home visits. We tried to confirm that people are not like, you know, manipulating this issue to kind of resell or whatever, or be part of a bigger issue. And we were delivering medication home to home. Ever since the blast, we have been able to help around 100 people from all over Lebanon. You can see that in the next slide. We kind of showed the statistical data. People from all the ages, like I think the most fragile were those between 40 and 60, because these were people with type 2 who lost their homes, so we had to help them too. And if we can move also to the next slide, we can see that we covered all the regions in Lebanon, not sparing any, not just the one affected by the blast. I know it's like a small, like this big effort led to helping a small maybe amount of people, but this was solely through education. It was solely through community. It was the power of advocacy and community coming together to kind of help other people. So I really feel so proud of this. I really feel so grateful for T1 International, honestly, because if it hadn't been for them, none of this I think would have happened. So a really big thank you to all of you guys. And it just starts with being aware of what your rights are, and things go from there. So that's what we've been able to do over the past year and a half, and I hope we can do more together. Thank you so much, Elizabeth.
Thank you so much. Thank you. It's really wonderful to hear that despite the challenges, you've done so much. And I think that's a theme for this panel. There's so many challenges, but such amazing advocacy happening. So thank you for sharing and for the work that you're doing. We're going to quickly move to Pilar Gomez in Panama to share about the work that she's doing there. Take it away.
Thank you, Liz. Next slide. Thank you. My name is Pilar Gomez. I moved to Panama 3 years ago from the UK to find a very different country and a very different health system to support people with type 1 diabetes. My daughter has type 1, my brother and my mom, amongst other people in my family, have type 1 diabetes. And when we moved to Panama 3 years ago, I realized the time to give back had come, and I founded this charity called Diabetes Latam. Our main objective is to educate and support children and teenagers with type 1 and their families. Next, please. Panama is a relatively small country in Central America. It has 4 million inhabitants. Most of the population lives in the city, in Panama City. There's a total of 7 pediatric endocrinologists in the whole country, 6 of which work in hospitals in Panama City. Like many countries in Latin America, we have a 3-tier healthcare system. Very few people have private insurance, either paid by them or by their employer. And then the rest of the population is covered by the public system. 70% of the population is under the Social Security program for people who are either employed or self-contribute, mostly employed. And about 30% fall under the Ministry of Health. These are people that are either unemployed or work in informal economy and have very little coverage. We believe probably this percentage will shift after the pandemic because we're seeing a lot of unemployment, so that 70% will probably drop. What we have found, we're a very, very young NGO. We've been operational since January, having won a grant from the Lions Club in Panama and the Lions Club Foundation. So we don't have too much experience, but from what we have been researching, one of our main concerns is a lack of information. There's no medical census of a type 1 diabetes. There's a rough census for type 2, and then they just take a percentage of that and assume that there's about 400,000 people in total with type 2 diabetes. And then from a percentage, we're trying to guess how many children and adolescents have type 1, but we still don't have the number. When we try to investigate the public system and even the private system, we find that there's no standardized documented practices describing care and coverage under each of the 3-tier systems. So really patients are navigating in the blind, and even a lot of doctors either don't have full awareness of what's covered under the system that they work, or they're very shy reporting to us these numbers. So in the time that we have been operational, what we have found is there's inconsistent quality and availability of care in each of these 3 systems. Access to insulin and supplies is not guaranteed, even with coverage. And so even people who are employed and contribute, they might find that there's availability of insulin one month and not the next. Navigating and using the system can be very cumbersome, very time consuming, and particularly with families that either don't have time or have a low educational level, this can be the difference between getting good care or not. And like in many countries in the world, the fear of losing a job translates into the fear of losing insurance and out-of-pocket costs that are probably impossible to cover. Next, please. With this in mind, what the Social Security program covers is they cover appointments, which can be either with a general practitioner all the way to a pediatric endocrinologist. It's really designed for those people living in Panama City. So if half of the population lives in the city, then the rest are probably abandoned by the system. Appointments are given in a scattered way, and there's, just like the example with Pakistan, there's a lot of queuing for HbA1c testing, collecting results, seeing a doctor, a nutritionist, a psychologist. So although the system is there, it's very difficult to access it without loss of time from work and from school for the children. Many children are on twice-a-day NPH and regular insulin, which on paper might work, but what we find scratching the surface and interviewing particularly teenagers is that it's a very limited approach to their lifestyle, and they experience a lot of burnout in the teenage years. Test strips and insulins are not always available, and sometimes even refrigerators are not available at home. The 30% of the population that falls under the Ministry of Health, these are uninsured patients, have no free insulin or testing kits, rely on donations, and will probably have to buy out of pocket. There might be some, in some cases, on some months, government subsidies, and other months they might need to buy it out of pocket. The minimum wage in Panama, the cost of living in Panama are very high. Minimum wage fluctuates between $600 and $650. Human insulin per vial, depending on where you go and if you get any subsidy, can vary from $3 to $40. Analogs are much more expensive, and pens and test strips are also very expensive. Next, please. Our realization is that we can't just sit back and look at all of this happening, and that a poor system exhausts individuals and even charities. And that's how we decided to create an advocacy committee, thanks to the help and training of T1 International. We set up a committee, we work very hard, we meet every week, we've received training and support, we've learned from others, and we have selected 6 initiatives. Next, please. We've been very ambitious on what we've selected. These are some of our members of our committee with the T1 International training materials. Next, please. And this is what we aim to. We want to participate in the implementation of 2 laws in Panama, which have been approved but haven't been implemented. And we fear that with the pandemic, these funds that were supposed to fund these 2 laws might go somewhere else. We're a very firm believer in education. We want our children and adolescents to have access to analog insulins. We want to offer them the flash continuous glucose monitor because we think that they can get much better control. We want them to have quarterly assessments with a pediatric endocrinologist and monthly insulin adjustments and the meal plan review over the phone or over telemedicine. We know this is very ambitious, but we want to aim high, and we're willing to work as hard as we need to do to reach our goals. Thank you very much.
Thank you so much, Pilar. It's, yeah, wonderful work that's being done and very much needed work as well. So thank you again for sharing. I'm going to again quickly transition to make sure we stick with time to Ivan Okoth in Uganda, who's going to share about some of the, again, very important work happening there and the situation for people with diabetes in Uganda and Africa as a whole.
Thank you so much. My name is Ivan Okoth. I'm a program manager outreach with Sonia Better Foundation and a T1D warrior. Next, please. I was diagnosed at the age of 16, and at the time I felt my life at a dead end, and I've never amounted to anything in life. I spent a full 16 years without knowing what type 1 diabetes was actually. And for me, the last 10 years have been a time for me to have hope. And within that time, I've also been able to turn out to be a lawyer. I've made it as an SNF outreach manager, promoter program manager as well. Next, please. In Uganda, survival for a T1D is a function of 4 things: public health infrastructure, poverty, awareness, stigma, and psychosocial stresses, literacy, and T1D education. The healthcare infrastructure in Uganda. The next one. Next, please. We have 4 pediatric endocrinologists in the whole country of about 20 million plus children. And 47.1% of the population is actually under 15. In Uganda, I actually find that diagnosis takes about 3 weeks for somebody to be able to be found to be with T1D, and many actually die before this happens. We have about 31 clinics in the country, and these provide free insulin under the Changing Diabetes in Children, as well as free syringes provided by the foundation, Sonia Better Foundation. However, there's no countrywide policy or strategy for type 1 diabetes. Poverty, there's a lot of food insecurity. In northern Uganda, we found that on average about a warrior spends about 3 nights without having a meal. The transportation is very, very high. Warriors take about 5.5 hours to get to the clinics, and most of this is actually on foot. Parents earn less than $1 a day, and we find that 95% of the children actually don't have a refrigerator or electricity to store their insulin. Awareness, stigma, psychosocial stresses. At one of our camps in Western Uganda, we found that 28% of the children have been ousted out of school by their management because they feared type 1 diabetes. And 76% of them actually feel sad or anxious about this condition. 56% of them reported that they were facing isolation in their schools because people feared that they were contagious or they were cursed. Literacy and T1D is a very important aspect. We find that in northern Uganda, 98% of the children actually do not understand how to do glucometer readings and have an issue complying with their T1D regimens. Equally, 81% of them need help from their caregiver to be able to understand and manage the T1D themselves. So numeracy, literacy, cognitive skills are actually a very, very big important issue for us to achieve good outcomes. The future I would like to see. I'd like to see a future where there's access to insulin, syringes, essential supplies, because for us warriors, insulin is life. And sustainability of these essential supplies is a source of worry, continuous source of worry for the caregivers, the warriors. And so there's a need to bridge the gap of delivering these essential supplies to the warriors. And that's why the government and the NGO, the broader NGO community, will be very important. I would like to see, maybe if you could come down, next slides. The next one, please. Yes, thank you. I would love to see an improved health infrastructure. The health workers are not as knowledgeable as they should be about type 1 diabetes. So there's a need to train them so that they can be able to pass on correct information about the condition to the warriors. And education is a very, very big component of what we do. Programs like the SNF Border Project were brought in as a COVID-19 crisis response intervention, but these need to be scaled up to bridge access issues faced outside this crisis context. Next, please. Advocacy, awareness, and outreach. The best advocate, we believe, is a person living with a condition. So building an army of warrior advocates is very transformative. So we focus on training of advocates to improve policy environments, raise awareness, which we feel is important. So pictured here are some of the advocates in the Pamoja Advocacy Program that I manage, and which is a joint initiative between the Sonia Beta Foundation and Type 1 International. There is a need, next please, there's a need to focus on social determinants of health. Poverty is endemic, and it increases the challenges with T1D, because how can you inject when you don't have food? How can you find transport to clinic? This only leads to stress. Optimal T1D outcome and requires carb counting and adjustable insulin. But how can you do that when you can't treat or count? Stigma in communities puts warriors at risk. Schools discriminate against warriors. This only leads to stress. Next, please. For us, community is everything. Without the T1D community, personally, would be nothing. It's even harder in the developing world that we live in. So you need support from communities that understand the condition. As the SNF outreach manager, my goal is to create a community that supports each other because we are stronger together. Behind me is a mural that has paintings, palm paintings of warriors. If you go to the next slide, please. Behind me, this mural represents the community that we have at every camp, because we believe that together we can. Thank you.
Thank you so much, Ivan. It's really, really great to hear about all that work, and we're glad to be able to work in partnership, especially for Pamoja, and the work SNF doing is really, really important. Again, moving swiftly along to our final panelist, and then hopefully we'll have time for a few audience questions. Kevin Wren is our chapter leader in Washington in the USA, and he's going to talk about the USA as a whole and some of the things that are going on there. Thanks, Kevin.
Thank you, Liz. Here's a picture of my dog Georgie and I hanging out in a Insulin for All shirt. I've had type 1 diabetes for almost 20 years. My grandma was diagnosed when she was 19. My father and brother both have it as well. I think we're all aware insulin prices are the highest they've ever been in history, with a quarter of us rationing. What's less obvious is the extent Black, Indigenous, and people of color face when accessing health in the US. Aside from the social inequities like police violence and racial bias in our criminal justice system, these communities are facing high mortality rates compared to white people. The burden facing Americans living with diabetes are formidable, so we have to work together to mitigate biases, exploitation, and inequity. From the national effort by federal legislators trying to make insulin more affordable, to the individual testimony from Insulin for All advocates, the inertia to address the insulin price crisis is growing. Yet while we fight for our affordable insulin, manufacturers continue to extort unconscionable profits from us, and a third of our country is at risk of developing diabetes. Next slide, please. Here's a picture of our Connecticut chapter with Kristen Whitney Daniels, who is going to give a talk about divestment campaigns today. The US accounts for only 7% of the global diabetes population, but makes up 2/3 of Eli Lilly, Sanofi, and Novo Nordisk revenues on diabetes medications, with $1.9 billion earned by Indiana's Eli Lilly in the last quarter. Last year, executives from all these insulin manufacturers contributed tens of thousands of dollars to the same legislators aimed at maintaining the status quo. This is a clear conflict of interest. While these companies profiteer, they pay nothing in federal taxes. They continue their scheming and anti-competitive practices while desperately holding on to the patents for our medicine, preventing others from entering the market and providing competition. Next slide, please. There's Lena, the DC chapter social media lead. Focusing on the pandemic, the conversations around affordable insulin stalled at the national federal level. Before COVID, the Senate Health, Education, Labor, and Pensions Committee requested the 3 insulin manufacturers to explain the skyrocketing price of insulin. Additionally, the House Congressional Diabetes Caucus was getting ready to introduce and propose legislation in spring, but was sidelined due to the outbreak. Lately, the presidential nominees discussed insulin when talking about their healthcare reform plans, yet advocates have yet to be included in this conversation. We're used as talking points, which is why it is crucial we reach out and demand a seat at the table. Next slide, please. Here's Nicole, who's going to be speaking today at 10:10. The power of patient advocacy can be truly seen at the state level through the numerous insulin copay caps, as well as California's generic drug and insulin manufacturing bill. Please take a moment to go to California's Insulin for All Twitter and Instagram to like and share their post about SB 852. In Washington, we passed $100 copay caps, and through our direct testimony and advocacy, established a position on the state work group for a patient with diabetes to work on controlling the cost of insulin. The bill was passed 95 yeas to 1 nay. We are building on that momentum to introduce legislation like the current bill in California, allowing us to set a floor on the market for insulin and protect our supply and medical chains, while also creating jobs and revenues for the state. Next slide, please. There's Kylene, AKA Black Diabetic Girl. Find her on Instagram and Twitter. She'll be speaking on Sunday. I think Dr. King said in Strength to Love really well. Please read that. Philanthropy is commendable, but it must not cause the philanthropist to overlook the circumstances of economic injustice which make philanthropy necessary. I think this explains the conflict of interest faced by the ADA and JDRF, who take pharma money. Our state chapters have cultivated strong relationships with supporters and partners. In Washington, we found common cause for accessible insulin and medications with Healthcare for All Washington, the AARP, numerous hospital associations, pharmaceutical associations, nursing and healthcare unions, as well as those representing BIPOC communities. Too often these groups are not represented enough, and the struggle is whitewashed. Yet, we make progress by sharing our stories, calling out the BS, and elevating each other's experiences. Next slide, please. Here's some of our Utah Insulin for All chapter members. As our voices are heard more and more, we will continue to make progress. We give context to the situation, detailing the struggle, encountering forces aimed at exploiting our illness. We need a seat at the table in order for us to be fully seen and to fully address these public failures. This coming election will determine much of the local, state, and national level, which will carry on over to 2021 and beyond. We are poised to make greater strides and build on the combined successes. We are making progress. In the words of the late, great Ruth Bader Ginsburg, real change, enduring change, happens one step at a time. Thank you.
Thank you so much, Kevin. It was great to see lots of chapters and various facts and looking forward incorporated there. Thank you so much. And thank you to all of our panelists. I think what's really clear through all of this is the challenges are many across the world. The challenges are big, but there's so much movement happening globally, and it just really shows the power of our global community, the power of taking action and taking one step at a time, even if it's a long battle. So this is really heartened me, and I hope to the viewers, hearing from everyone around the world. This is obviously a small sample of all of the advocates around the world who are doing this work, but we're just really grateful to all of you panelists for sharing. We do have a few minutes for Q&A. So I'm wondering if anyone in the audience has a question for specific panelists who spoke, or for broadly for all panelists, who we would ask keep answers very, very brief because we have limited time. So, well, I think my question, which I think has come through some other questions that were answered individually, is if any of the panelists would like to chime in and share just a few words about what gives them the most hope looking forward. So I know you've all touched on some of this and you have very specific advocacy goals, but if you can just share a few words about you know, what you feel most hopeful about when it comes to your advocacy and the community. Is it okay if we just go in order of the speakers? So if Sana has some reflections, and then we'll go down the line that way.
Thank you, Liz. I feel very hopeful because when I talk about this on-ground support program, what it has really stirred up is the interest of the community in this cause, because most of our donors, around, you can say 80%, is the diabetes community itself that are helping the other diabetes community. So when they hear the stories, when they hear about the cause, it really stirs up that passion in them to be able to advocate for it, with the policymakers and with the other healthcare organizations that can make an impact in the longer run. So that's the hope for us.
Definitely. Thank you, Sana. Cyrine, do you have some thoughts?
Well, yes, for me, at least here in Lebanon, because we had different objectives, just the fact that more people are coming out and talking about their diabetes is a milestone, because people here used to hide their diabetes and were not very open on talking about it to begin with. So like seeing people reach out saying, hi, I'm diabetic, I'd love to talk to other diabetics, I want to reach out, that for me is like a first step into creating the kind of community that pushes for change. We need more of that. We need more of, it was so hard to find diabetics, in Lebanon, even over social media, because they don't just show it. So things like that, just pushing the community into coming out of that box, sharing their diabetes, sharing their struggles, to know where we should start supporting them and how we can come all together as a community to kind of push for change. So that's the case of Lebanon.
Yes, thank you so much. Wonderful. Pilar.
I think what gives me the most hope is to realize that when we work in advocacy, we're influencing the system, not necessarily an individual. And when you manage to make even the slightest change to a system, you impact everybody under the system. So it might be a very long-term goal. It might be painful. I think it's not a popular role to play when you work in advocacy, because it's very easy to step on the toes of the medical community, of the industry, of government officials, especially in countries where there's a lot of corruption. But I see absolutely no option, because if I can make one little tweak to the system in the next 1, 2, or 5 years, I know that once that becomes policy or that becomes a law, it's going to help everybody in the community forever.
Such an important point, and I think that's why it might take a little bit longer, but why it's so crucial. Thank you. Ivan.
Yes, thank you. What gives me the biggest hope is that the community has started providing examples from within themselves. The warriors are providing examples to other warriors with their good management, with their ability to overcome the adversities of life. And for me, that is the one thing that is giving me hope, because they are rising up, they are making the noise, they are being heard, and it's counting.
Yes, thank you. Yeah, couldn't have said it better. Kevin, any final thoughts on what gives you hope?
Yeah, I'd just like to echo what Cyrine and Ivan said about harnessing the network, like just meeting other people in our country and then around the world that are struggling with this is really inspiring to know that they're on the ground working. And then kind of what Pilar said too is just making that incremental progress and injecting yourself in and actually making a difference and seeing that come through and seeing other advocates do the same thing. That's what gives me strength.
Yeah. Again, we're all connected through this this hope. There are struggles, but again, seeing each other and kind of supporting each other through all of this and the community. The name of the workshop, got to get that in there, change the community. But truly, yeah, seeing and knowing the work that's happening and that it is possible to find hope in very, very dark times is I think what we all need. I know it's what I need. So again, thank you all for being here and for being a part of this. We're so glad to have you helping us kick off our workshop for the next 2 days. And you know, we'll keep talking and we'll keep advocating together. I know that's for sure. And I'll close it there because I want to leave it on that beautiful, hopeful note. And just to say thank you one last time.
Welcome back, everybody. We hope you appreciated hearing from our panelists on the Global Perspectives panel. As we return from the break, it's my pleasure to introduce 2 incredible women who are doing inspiring work to further the Insulin for All movement, Nicole Smith-Holt and Jazmine Baldwin. Both have lost loved ones to insulin rationing and will be sharing their personal journeys to advocacy with us today. Nicole Smith-Holt is the Minnesota Insulin for All chapter leader and T1 International Charity Ambassador, and Jazmine Baldwin is a CNA and nursing student currently living in Raleigh, North Carolina. Nicole and Jazmine will each share their stories and then participate in a conversation moderated by T1I's Senior Advocacy Manager, Allison Bailey. We'll have a Q&A portion following the conversation, so if you have questions throughout the session, please feel free to ask them in the Q&A box and we'll select a few to answer during the Q&A. Thanks to both of you for being with us today.
I just wanted to thank you all for participating in the workshop this weekend, and it really means a lot to me that you're here choosing to listen to Jazmine and myself today. So, Alec, many of you have heard my story several times, but I was asked to share as if I was sharing for the first time. So Alec was just turning 24 when he was diagnosed in 2015. He was really sick, and we all thought that he had the flu. He took himself to urgent care and called to tell me that he was diagnosed as a type 1 diabetic. I immediately started research on WebMD and Google because surely this doctor had no clue what he was talking about, because everything that I learned when I was in physical therapy school said type 1 is found in children, and Alec had always been healthy. So this doctor obviously did not know what he was talking about. Well, turns out I was wrong. Alec did surprisingly well adjusting to his new life. We all experienced some highs and lows within the adjustment period, no pun intended. So type 1 was definitely a learning curve. Fast forward 1.5 years to December 2016, and Alec got a promotion. He was making better money, and his new job title was general manager. It came with a nice pay raise, but no insurance and no other benefits. Alec decided that since he was making more money, that it was time to ultimately venture out on his own, and he found an apartment closer to his job, and he was excited. I was scared to death, and I asked him to find a roommate, but he insisted on living alone for the first time because he was craving freedom and independence. Fast forward to May of 2017, Alec was still 25, just getting ready to turn 26. On May 20th of 2017, Alec turned 26. Should have been a reason to celebrate, but my fears increased because he was about to become uninsured. June 1st of 2017, or D-Day, Alec officially became uninsured. June 22nd, Alec went to the pharmacy the first time to refill his prescriptions without his insurance and left empty-handed. The price he was asked to pay was $1,300, and he only had $1,000 in the bank. On June 27th of 2017, my worst nightmare came to fruition. I was at work with a home care client and received a call that Alec's body had been found on his bedroom floor. Not 5 minutes before that phone call that I got, I had actually sent Alec a text message reminding him that I was stopping by that evening to deliver a new dining room table for him. The medical examiner reports that there was no insulin in his apartment and that it had appeared that he had somehow extracted every drop of insulin that was left in his pens. Because typically we know that when you throw out that pen at the end, there's a few units left that just gets tossed out. On June 30th, that would have been Alec's next payday, and he would have had enough money on him at that time to buy his expensive ass insulin. Alec was stubborn, and I believe he did not ask for help because he was trying to show us that he was responsible and he could live independently. And I'm positive that this is why he didn't ask me for money. He knew I would give it to him, but I would also have asked him to move back home so that he could afford his prescription meds. Alec loved life. He was silly, he was active, he was smart, and he had the biggest heart. Nothing meant more to him than his family and friends, and his goal had always been to make people happy. Alec loved to travel, play practical jokes, camp, hike, fish, and most of all, watch and play sports. His goal ultimately was to open his own sports bar. Since Alec's death, we have teamed up with the amazing organization T1 International. They have provided me with a platform to share Alec's story and to work on policy changes so that someday we can stop adding names to the growing list of those who have died due to the lack of access to affordable insulin. My journey, my fight, has taken me to Indianapolis on several occasions, to Boston, to Canada, to Detroit, Miami, and Washington, D.C. I've had the opportunity to work with state and federal legislators, and we've been able to raise awareness of this insulin crisis that plagues the U.S. Our fight's not over. Even though we currently have legislation in place in Minnesota, Alec's law does not lower the price of insulin, and it doesn't cover all that needed. My goal is to help create legislation on the federal level that lowers the cost and benefits all. Pharma is currently suing us in Minnesota to stop our bill. We're working with a team of lawyers and the Attorney General's office to prevent this bill from being overturned. And once we achieve that, it will open up the ability for other states to implement a similar policy for emergency insulin. So I know Alec has walked beside us every step of this journey, and I know he is in a better place and helping to make magic happen. I look forward to the day that I get to heaven and I can receive my Alec hug once again. So in closing, I want to take a moment of silence to remember those that we have lost. These are only a few of the names. We know there are so many more. And I encourage you to remember these names, say them often, and help us to keep the list from growing. Thank you.
Thank you so much for sharing your story, Nicole, and for your continued advocacy. For those who don't know, in addition to Nicole's being in those different places that she named, she's also currently on 2 billboards in Indianapolis. So it's great to have that presence there, even though we can't be in person this year.
My name's Jazmine. I am a nursing student and CNA who lives in Raleigh, North Carolina, and the older sister to Jada Lewis. She passed last year, June 22nd, 2019. Jada was my absolute best friend. I talked to her about any and everything. She brought out the best in me. For instance, I absolutely hate taking pictures. And every time I would drive home to Virginia to see my family, she would insist that we take a selfie together. So the majority of the pictures in my phone that are of me, she took. She was very much into fashion. She was 6'5", so it's really hard to find clothes that fit her. So she would, just do her own thing. And so she had her own sense of style. And she really enjoyed doing that for herself as well as other people. And it really lent itself to her interest in drama. She was in several plays in school as well as in extracurricular programs. And she was just a clown. I think that's the best way to put it. She was an absolute clown, and we loved her for it. I remember back in June, my mom called me. I was at work, but I answered anyway, because if she calls me while I'm at work, it's probably important. And she told me she was in an ambulance with my sister on the way to the hospital. I immediately go into, big sister / nurse mode, and I'm trying to find out everything that's been going on. Apparently she'd been sick for a few days. She was throwing up. She couldn't eat, very nauseated. She got to the hospital. They admitted her to the ICU. She was in DKA, and she stayed in the ICU for a few days before moving down to a less intense unit. I was actually with her that first weekend that she was in the ICU. And I took 3 days off of work, and I went and I stayed in the hospital with my sister. She was discharged home the following week, and she was home for about a week before she passed. I was able to talk with her about, what happened, how she ended up in the hospital at all. And she said that she hadn't taken her insulin in about 3 weeks. As a type 1 diabetic, she knew the importance of insulin, so I'm just flabbergasted as to, how has she not taken it for 3 weeks? And she told me that it would have cost her $300 to get her medication, and she didn't have it. We're kind of a proud family, so I'm not surprised that she didn't ask for help getting that medicine, but at the same time, it's really frustrating that she would have had to ask to help pay for life-saving medication. And so my sister died. She couldn't afford $300 for her medication, and so she died. And it's been over a year, and it's still having its effects on our family. We're all just still devastated, and it's hard to believe that she's not here with us anymore. And it's really painful and, again, frustrating that, the reason that she's not here, it's because she could not afford a medicine that she literally could not live without. So while it's been difficult to have to adjust to life without my sister, I am grateful that it's brought me to this sort of just advocacy platform that I have now. I found T1 International, and they've been incredibly helpful and supportive, and it's given me hope that maybe I can be part of the movement. I can help change things so that there aren't any more cases like my sister, and it's really been a blessing, and I'm grateful for that. So now here I am. More than a year later after losing my sister, and this is the second time I've spoken at a T1 event. I was at the protest outside Eli Lilly last year, and that was it was almost a surreal moment, but it was really, really powerful to be around so many people who are so passionate about this cause and genuinely want to see change. And so I'm hoping to continue that as we move forward, even in the pandemic, just to be able to speak up for people who need, that kind of support.
Thank you so much, Jazmine, for sharing your story. It's so powerful, for sharing your story of Jada. It's so powerful to hear about Jada and about Alec and about the stories of all the folks that we've lost. And it's our goal with all of our advocacy to move forward so that this never happens again. You sharing your stories, helps us move ever closer to that goal, because it's so striking for people to hear about the fact that this happens here in the United States. Just so the audience is aware of what's going to happen next, we have some questions that we're gonna ask for a few minutes. Also, the Q&A is open. If you have any questions for Jazmine and for Nicole, please go ahead and ask them. But yeah, just to start with some of our questions. So one of the first ones I wanted to ask is, what gives you strength when you are tired? Jazmine, we can start with you.
So I have, I don't want to call it like a shrine, but there's a table that I have in my house, and in the middle of it is a picture of my sister. I have her obituary there. I have all sorts of cards that people have sent me. Some things that she liked, a lot of pink things, because that's her favorite color. And if I'm having a tough time, which is pretty often because I'm in nursing school, I look over at that table and I see her and she's smiling at me. And that lets me know that I'm going to be all right, because even though she's not here, she's here.
Yeah, definitely. Nicole, what about you?
I think what gives me strength is, you know, hearing other people's stories, knowing that Alec was not alone in this craziness, that his struggle was not just his struggle, that people everywhere are encountering the same issues, and knowing that, you know, we want this list to stop growing. We don't want to keep adding names. I don't want to keep hearing, you know, the horrible outcomes of having to ration insulin. So I think that's what ultimately gives me strength, is hearing that, you know, the fight needs to go on.
Yeah, certainly. What has been the hardest part of sharing your stories?
The hardest part, I guess it's twofold. One's talking about my sister in the past tense. I don't think I'm ever going to really get used to that, but it's a fact. She is no longer here, so she's like, it's a was. And then also, even though I'll tell people, I'll talk about Jada left and right for hours on end, but the fact that she's like, it's not an isolated incident like that. It's all too common for you know, these stories to exist, and that it's mind-blowing.
Yeah, definitely is. Nicole?
Yeah, I think the hardest part for me has been, you know, I'm a very introverted person, so finding my voice and finding the platform to share my story, but then hearing all the negative feedback at times. You know, hearing comments that I'm ultimately responsible for my son's death, that I should be in prison, that I'm selfish, that I'm a bad mom. A lot of the negative things that I've heard from both inside and outside the diabetic community at times have shaken me. But I know that, you know, the negative comments are far few in between. That, you know, the positive stuff that we're doing outweighs that.
Yeah. And you have to know, the entire diabetic community, you know, all the questions and answers that we've gotten so far are actually words of encouragement, because we all feel so strongly, and we all are so appreciative of the fact that you raise your voices and that you talk about this, and, you know, over and over, that you keep talking about this. It means so much to the community. What's one moment or experience that has made your advocacy journey worth it?
I'll say right at the end of the protest outside Eli Lilly last year, a woman came up to me, and I had no idea who this woman was, but she said, I'm sorry you lost your best friend. Can I give you a hug? And we hugged for like a solid 5 minutes. And that let me know that people genuinely care. And if this one woman, this one stranger in the middle of Indianapolis, where, you know, I live hours from there, is willing to show me that kind of love and support, then there's got to be more. And there have been plenty of other times like that. But I think that first time a stranger came up to me and said, you know, I see you, I hear you, I love you. Thank you for what for sharing. And that's kind of been like that lit a fire under me. And it's made this a very, very rewarding experience.
Yeah. Nicole?
Yeah, I think for me would probably be finally passing the Alex Smith Emergency Insulin Act. Finally getting, you know, a one-of-a-kind bill signed into legislation. I think that that was probably, you know, the highlight so far.
Yeah, that was a big moment, and I know, yeah, the photo from that day, the photos from that day, those were very, very powerful photos, and I know we were all rooting for you as that was getting passed. So we are starting to get a couple questions in, but yeah, just to go through a couple more that we had. What do you want people to know most about Alec and Jada?
Jada lived in the moment all the time. And I think that's a valuable lesson to learn, because obviously life is not very long. She only had 24 years of it. But I think she made the most of it. I really think she did. And that's something that I've tried to incorporate into my own life, which is hard at times, but it's that was her. That was her.
Yeah.
Yeah, I think I want people to know how kind Alec was. You know, he was one of the most kind and sensitive and loving people that I've had the pleasure of meeting. And he gave the most amazing hugs.
Yeah. It's always nice when you find someone who gives those sorts of good hugs that really, you can feel it to your core. So I know how important that can be. One of the audience questions that we just got, so they offered their condolences to both of you and thank you for your work. And they said their 22-year-old daughter does not easily discuss her type 1 diabetes. Would you advise them to push those hard conversations and try to make them more common in light of your losses and your hindsight?
Yeah, absolutely. I think, you know, they're not easy conversations. You know, I think Alec really felt isolated because he knew nobody else who was a type 1 diabetic. He had no resources to lean on. He had, you know, no role model to model his behavior or his disease with. But I think if we would have done a little more research, we would have found, you know, there's actually a lot of people, you know, even in our own community, who I have found since he passed away, who are type 1s, that, you know, people just keep it so quiet that you just don't even know that your neighbor. And we found out my neighbor is a type 1 diabetic. I mean, and they used to work together. You know, Alec used to help him with his yard work, or, you know, do different things around the house. And he never knew, neither one of them knew that they were each other, you know, either one of them were a type 1 diabetic. I mean, that would have been a huge, you know, a huge plus for Alec, somebody to talk to. And those conversations are hard, but you need to have them, especially when when it's moving towards, her being independent and getting her own insurance and the cost, and those type of conversations should probably start now.
Yeah. Jazmine, what do you think?
Well, I don't have any kids, but I think speaking from the child standpoint, it's always going to be kind of awkward talking about anything like that with, especially with a parent. But I think as long as you have that relationship of trust, just mutual trust and respect, that like you're going to have that conversation, but it'll become less maybe embarrassing or awkward or just uncomfortable once you finally break the ice there.
Yeah, definitely. Well, let's see a few more of our questions. So what are some of the challenges that you've faced as an advocate?
I think, so I mentioned I'm in nursing school. People listen to you a little more when you got a couple letters behind your name. So those letters I'm reaching for are RN. So when like as a student, when I try to speak about things, people kind of write you off. And so that, I guess that's just coming from like a healthcare perspective and working in healthcare like that. But otherwise, folks are pretty willing to listen to what I have to say and appreciate that I'm saying it. But definitely from being in a healthcare standpoint, just it's a little bit less respect for students as opposed to the registered.
Yeah.
Yeah, I think, dealing with all of the misconceptions that are out there around diabetes, having to first focus on education and educating, the general public. And even I have encountered having to educate healthcare professionals on the difference between type 1 and type 2. And type 2 is absolutely, involved in this conversation. But when we're talking about, specifics, trying to get that stigma out of people's, minds over, how somebody develops diabetes. It's very, very frustrating. So I think that's been the hardest part, is having to go so deep into education versus, just, demanding affordable insulin.
Yeah, definitely. Well, I think we have time for one more question. So I will end with, what is your hope for the future? Jazmine, we can start with you.
I don't want anyone to ever feel how I felt when my sister died. I don't want anyone to have to experience that again. So I really want the United States to get on board with what seems like a large part of the world has figured out, that healthcare shouldn't have to cost people thousands of dollars a month. It shouldn't be a decision to pay your rent or go see the doctor about the fact that you've been throwing up for 3 days. That's not a decision that anybody should ever have to make. And I don't want that to happen ever again.
Certainly. Nicole, what about you?
Right along the lines of what Jazmine said, healthcare reform. We shouldn't be living in a society of for-profit healthcare. So hopefully, we will be able to, I think that we'll be stronger as an advocate group if we can, raise our voices and unite with others and, create this huge movement where our entire healthcare system is reformed from the top to the bottom.
Yeah, definitely. And you both have been such a help with moving us in that direction. Your continued advocacy is so very powerful and makes such a huge difference, and the community really can't thank you enough for all that you do. I think, yeah, like I said, that was our last question. So thank you so very much for coming and speaking with us today and taking the time. I'm going to hand it back to Eli so that he can introduce our next session.
All right.
Thank you so much, Allison, Jazmine, and Nicole. In Judaism, when people pass, we say, may their memory be a blessing. And I'm touched by how you both shared how Alec and Jada were a blessing in life. And I'm inspired by how you're working to make sure that their memory is a blessing to everyone with diabetes who relies on insulin by fighting to make the world a better place. So thank you again. Moving on to our next speaker, we all know that 2020 has been an atypical year, and the external stresses we're all feeling can be even more significant when someone is balancing them with a chronic illness like diabetes. Today we have Dr. Harpreet Nagra with us to talk about what diabetes psychology is and how it can help patients with diabetes cope with the variety of anxieties, stresses, and variables that come with diabetes in the time of COVID-19. Welcome, Dr. Nagra.
Thank you, Eli. Is everybody able to see me at this point? Hopefully, yes. I am just currently feeling all the feelings that are coming up from Nicole and Jazmine and Allison kind of talking about the stories that they just shared. I wasn't able to sit through or follow through all of it, but I'm just recognizing that how important diabetes psychology is in introduction to when you're first introduced to diabetes, the diagnosis, how much it impacts family members. We're going to talk about all of those pieces today, but always hearing the lived experience and the individual stories, it's so impactful. And no matter how many times you kind of hear different experiences, each time it hits you on a whole other level. So I just want to say thank you to our previous speakers for sharing everything that they just shared. So I wanted to speak about this area of diabetes psychology that's somewhat of a specialty area. Not everybody knows about it, and I want to make sure that more people are aware of this particular resource. Just because there's so many feelings that go hand in hand with managing a chronic illness like diabetes that it's rarely talked about, the emotional side that's really rarely talked about, that there is more support available for, but we want to make sure that just like we're trying to make sure insulin is available, that we're also providing this emotional side of support through the healthcare system. And of course, there's going to be lots of need for healthcare reform before even that is possible. So I'm going to go ahead and share my screen here and get us started. So as Eli mentioned, my name is Dr. Harpreet Nagra. I am a diabetes psychologist. That's the official label that I go by. I have a doctorate in counseling psychology, and a lot of my training was focused in health psychology, but I specialized in diabetes. Partly because I have family members and friends who, I don't have diabetes myself, but I've seen the emotional struggle that folks go through in the day-to-day management of diabetes that's rarely talked about. So as I was trying to figure out what I was going to do with my career, I really wanted to select a specialty where there wasn't as much discussion, there wasn't as many resources, and diabetes is that, at least from my end of things. I'm currently working as a diabetes researcher at University of California in San Francisco. What this means, what we're looking at is a little bit different than what you all may have heard of in terms of diabetes research. We are looking at what are the emotional interventions, psychological interventions that we can be providing to folks to help reduce some of the, again, emotional and behavioral challenges that come up with managing diabetes on a day-to-day basis. I see about 10 to 15 folks on a weekly basis that are managing either type 1 or type 2 or MODY or late onset diabetes, like all of those different variations, as well as for some folks managing a mental illness in addition to the diabetes management. So I'm very privy to sort of a lot of the examples that were shared already. And I want to make sure that as a professional who has tools and skills that I can be providing to clients and folks living with diabetes on a day-to-day basis, that more of us are talking about this and available as a resource to the general public, because this should not be a coveted service that's only available to the elite in some way. And then by doing that, actually, I'm also working as a faculty member just because I want to be teaching the next generation of mental health providers about the importance of conditions like diabetes and the impact that they have on not only just the physical side of things, but also the emotional aspects of everything that comes with it. So I try to do my best to be an advocate in all of those directions. So I want to just do a quick survey of everybody that's here of how many of you actually knew that diabetes psychologists existed. So I don't know if you have the raise your hand feature available to you, please go ahead and use that. The fact that I'm only getting like 1 or 2 responses, I'm going to take that as a hint that not many of you knew. So again, this is a service it's not newly available, but I think it's been kind of denied to a lot of medical settings because, again, mental health is not considered as available or as significant as physical health. But we all know that when you're feeling stressed, that impacts your physical health and the way that you're able to take care of yourself and so on. And we'll talk about the impact of the various emotional factors on diabetes today.
And Dr. Nagra, just so that you're aware, the chat function should be open for this part, so people may be responding there as well.
Oh, perfect. Yes, I did see that. Yeah, I'm seeing some responses coming through. Thank you for Allison, to Allison for following me on Instagram. And we'll talk about that as well. Yeah, so there's not a whole a number of resources that are available. So let me just start out with the basic function of what diabetes psychology is. So first of all, there's the general psychology that's out there. So general psychology will look at how are your thoughts, how are your feelings, how are your beliefs impacting the types of actions that you take on a day-to-day basis, right? So that's general psychology. That's what a psychologist can provide support around. When we're talking about diabetes psychology, we're looking at how your thoughts, feelings, beliefs, actions impact your direct relationship with diabetes, so your health outcomes. So things like your day-to-day engagement with diabetes tasks, or your A1C, or sort of your willingness to talk about diabetes with others, how it might be impacting your relationship. So every sort of emotional impact that we can think of, I'll give more examples as we go through, it allows us to process some of those ideas with a professional who can, again, provide additional tools and skills along the way. So simply put, it's the emotional and behavioral side of diabetes that I would say not a whole lot of medical professionals are privy to also, because the focus has been, and there is a lack of training on the emotional impact on physical health over time. So some of the common psychosocial concerns that I would help provide support around for anybody who would come in to see me include things like adjustment and acceptance to the diagnosis when you're first diagnosed. I mean, you all have been, I'm sure, aware of all the variety, the flood of emotions that come on once that occurs. So the idea of managing the shock of receiving the diagnosis, the grief around the diagnosis, the potential role change shift that might happen for you once you receive the diagnosis, the changes that it lends in your relationships, in your work environment, in your school environment, if you're a young kid. There's just your life shifts in so many different aspects that are rarely talked about. And a lot of folks, whether they're coming to see me immediately after they've been diagnosed, or if they're coming to see me after 50 years of living with diabetes, not everybody is at the same level of acceptance of the diagnosis. There are still folks who might be 55 years in and may still have challenges in just accepting the fact that they have type 1 diabetes, and just the diagnosis and just sitting with it. And I think what tends to happen is that when there is a lack of acceptance, and I'm not blaming the folks who are living with it, because I think this is such a challenging experience to be dealing with on a day-to-day basis. When there is a lack of acceptance, though, it prohibits us from making the physical changes, the behavioral changes that we might need. So the habits that we might need to put into place to be taking care of ourselves on a day-to-day basis. And sometimes if you don't know anybody in the community, as they were talking about in the previous session, you feel alone. There's isolation. There's possibly a sense of shame. There's possibly a sense of guilt of why did I get this diagnosis and how did I get it? And that when a lot of your energy, emotional energy is spent in managing those emotions, then the day-to-day diabetes tasks, I think there's about 150 diabetes tasks that are necessary to sort of just maintain your diabetes that get in the way of allowing you to really fully pay attention to those diabetes pieces, because the emotional impact is so great. We also talk about diabetes distress. So this is what I was talking about with the 150 tasks. That's not a research number, but it's something that's been out in the clinical diabetes community that we often talk about, that, in a given day, if there are 150 tasks that you have to complete just to manage your diabetes, you're not going to have a whole lot of energy, emotional energy, or possibly physical energy to devote to other aspects of your life. And even if you still muster up the energy to do so, it's very challenging to make that happen on a consistent basis, every month in, day out, for multiple years on end. And that is where a lot of diabetes burnout tends to happen as well. So burnout can look like wanting to step away from diabetes altogether. So feeling like if you can't give it 110% of your energy, that it's not something you want to do at all. So a lot of folks tend to end up with some like perfectionistic types of thinking. So going from wanting to do either 110% or nothing at all, or 0%. And that shifting, that going back and forth, can also, again, be wearing on you. Perfectionism, like I was saying, comes up quite often. There's, again, a lot of messaging that you're getting either from the healthcare system, from family and friends, your own internal sort of early childhood experiences, early life experiences that are saying, if you're going to do something, you should do it to your utmost best ability. And if you're not, then, you are not doing it right, or, you're doing something wrong along the way. So what we do is we talk through what some of those perfectionistic pieces might be for the client, and how to go about making some changes that are appropriate for you, that are personalized to you. Again, I've been talking about coping with diabetes within relationships. So, I have a few clients who have shared with me that, when they first were diagnosed and they were dating somebody new, they were terrified about sharing their diagnosis with their partner, this new person that they had been dating, because they were worried that the person was going to turn around and run away and say, you know, they can't be in that relationship. So that in itself can be traumatizing as well. And it can, again, make you want to hide your diabetes diagnosis even more so. So it's something that I think we don't always acknowledge. Again, the day-to-day or the minute-to-minute changes that are happening for all of us in terms of how it might be impacting our relationships. Navigating the healthcare system. I know that you know, a majority of this workshop is going to be focusing on how do we better improve the healthcare system to make sure insulin is a regular resource that's available. In addition to that, I think mental health is a significant part that's missing from the conversation. You know, insulin is absolutely, this is something I always say, insulin is absolutely the treatment for managing diabetes, but it doesn't help you cope with the emotional weight of managing diabetes. And that is where we need more support, more mental health professionals in the clinical settings immediately after the diagnosis is made, to let people know that they're not alone in their experience, they're not isolated, that there is a not only a medical team, but a mental health team that's available as a resource. And how can they be talking, and what kind of communication skills do they need to be developing for themselves? What, you know, for the support team that's available to them, to have more of these conversations with their family and friends. There's so many folks that I sit with in my office who say, you know, I really want to be able to share and seek out support from my family members and my friends. However, I know that as soon as I do that, they're going to start nitpicking, or they're going to start policing what I'm doing, or they're going to possibly invalidate my experience, or they don't truly understand. It doesn't feel safe for me to share some of this information. What I'll say from the psychology world is that we know that the best way to access healing is through community. We are social beings. We need social support in order to even amplify our healing to some extent. And if those types of challenges are present, I would want somebody to have that mental health resource, at least for, you know, even if it's a temporary time period, to be easily accessible to them, so they can process whatever feelings might be coming up until they develop the skills. Or, you know, we bring in family members to help the entire family talk about the diagnosis, so there isn't this sort of one person shaming that's happening along the way. To collaboratively think about what are the skills that are missing for this group. How do we continue to talk about some of the challenging aspects of taking care of diabetes and dealing with burnout as a community. Additional areas that we might be that you can focus on with the diabetes psychologist include things like carb counting or eating distress. I have many young women who come in, even young men who actually, age has nothing to do with it, to be honest. Because diabetes, you're constantly thinking about, you know, every plate is a math problem, right? So you're constantly thinking about carb counting and the carb to insulin ratios. There's a lot of distress, a lot of possible disordered eating that can develop from that as well. So these are just some types of concerns that are available to talk about when it comes to discussing diabetes and the emotional impact of it. I see some really great questions coming through our chat feature here, and I'm going to take some time at the end to answer all of them. So just hold on tight. What I do want to say is that what I want to focus on for today is the difference between diabetes distress and depression, because I think a lot of times there's utmost confusion about oh, you're just depressed, that's why you're not doing whatever you might need to do with your diabetes tasks. That is completely untrue. While some folks are managing depression types of symptoms, diabetes distress and depression are two separate things. And the reason we know this is because whenever we have done research studies to look at the impact of psychological interventions or any type of emotional intervention on a person's level of emotional distress around their diabetes, we've seen very quick changes around A1C levels, which is, I know everybody is probably sick of hearing, but that's what the healthcare system uses to measure whether or not something is effective, right? We've seen changes around A1C levels. We've seen changes around blood sugars. We've seen changes around how they're managing how folks are managing their stress levels on a day-to-day basis, how they might be engaging with, again, the diabetes related tasks. So how often they're checking their blood sugars, how often they're bolusing, how often they're carb counting, what kind of tools they're using to carb count. All of those pieces shift whenever there is just this simple acknowledgement that diabetes distress might be at play here. The sad part of all of this is that a lot of folks are either unable to or don't realize or are unaware or just don't have the resources to, again, access those mental health services until they hit a point of burnout. That is when medical professionals will typically say, okay, maybe you should go see somebody, but there's so many things that we can be doing on the preventative end that could allow folks to truly sit with and acknowledge the distressing feelings that are coming up and acknowledge that this is a hard thing to be doing. It doesn't have to be that something that you just kind of hold on to and kind of internalize for yourself and end up kind of beating yourself up about over time. Diabetes distress, because it can be chronic, that is a significant factor here that differentiates it from depression. Depression, there are the treatment for depression, the treatment for versus the treatment for diabetes distress, they're two different things. A psychologist typically, the gold standard for depression is typically, in terms of treatment, is typically a combination of medication, if appropriate, as well as some type of talk therapy. And there isn't exactly a gold standard just yet for diabetes distress because there is such a lack of acknowledgement of it so far. But what we're noticing is that simply engaging in some level of talk therapy is helpful for a number of folks out there. So when there is acknowledgement, we see changes in adherence levels, we see changes in quality of life, we see changes in relationships, and everything else that I've kind of mentioned so far. So I'm getting ahead of myself, folks. One resource I really wanted to mention as part of this talk, because there are a number of advocates out there that might have access to more folks who are possibly experiencing diabetes distress, is called the Diabetes Distress Survey. I have the link here, and if these slides are available, I'm not sure if they are or not. Please feel free to use this link from the slides. But you can also just Google Diabetes Distress Survey and you'll be able to find it. This particular survey helps you, it was developed by psychologists. So if any of you are familiar with diabetes psychology, you'll know names such as Bill Polanski, Larry Fisher. I feel like those are the sort of two most common ones, but Bill Polanski is the guy on diabetes burnout within the psychologist world. But they were the key researchers who developed this particular survey after multiple research studies. And what this particular survey allows you to do is identify what aspects of diabetes distress are you feeling most distressed about. So it'll ask questions such as, I don't feel skilled at managing diabetes as much as I think I should be, right? Or I feel like I don't eat as carefully as I probably should. So these types of items are assessing 7 different types of diabetes distress that exist or that we've labeled thus far in the diabetes psychology world. And these are the 7 types of diabetes distress that one could experience. So, for example, powerlessness. I don't know how many folks I've sat with who just feel discouraged about their diabetes, who feel like they're getting such negative messaging on a regular basis from doctors from different sources saying that, you're going to develop complications no matter what. Or let's say 20 years ago, folks were getting messaging 20 years ago, 30 years ago, even 10 years ago, that now that you have this diagnosis, you are basically not going to either you're going to experience tons of negative outcomes, not be able to have children, lose limbs. You know, you all know the complications. You're already distressed about them, so I don't need to review those. But there's this feeling of no matter how hard you tried, you're going to end up with negative consequences no matter what. And that sense of powerlessness is a sort of this meta feeling that's there all of the time. It influences every aspect of how you engage with your diabetes. So the next time you might have a high blood sugar, if you're feeling that sense of powerlessness, you're possibly going to say, why should I even treat this? Or do I even, is it even going to matter if I give myself the correct insulin dosage? Or again, no matter how correctly I counted my carbs, I'm still going to have complications. So why would I even continue to make an attempt, right? So that sense of powerlessness starts to dictate your day-to-day actions around diabetes. That feeling guides your responses. Other types of distress might include management distress, so feeling disappointed with your self-care efforts. I don't know how many folks I've sat with who said, I counted my carbs as thoroughly as I possibly could. I gave myself the correct dosage of insulin, and my blood sugar was still high, right? And I didn't know what else to do other than just sit there and wait. Or I didn't know who to reach out to because I don't have, again, access to the appropriate resources that could potentially walk me through or talk me through what to do in that situation. There's very much unfortunately, I don't want to sit here and bash the healthcare system, but I do think there's lots of gaps that we're still missing when it comes to chronic healthcare for chronic illnesses. And that includes things like being able to provide 24/7 on-call type of care for folks who are managing diabetes for the first time. There's very much this mentality of fight or flight. You just kind of sink or swim, do what you need to, call us if you have any major problems. And you don't want to end up in the emergency room every single day either. So that type of management distress can get in the way, and the healthcare physician distress is what's labeled on here, number 6, can get in the way of feeling like you are properly managing your diabetes as well. Hypoglycemia distress, so feeling like you can't ever be safe. If you've ever had a hypoglycemic episode, you can feel kind of helpless around that, feeling like I don't know when my next low is coming. Or if you know of folks who may have suffered negative consequences from a hypoglycemic event, that can amp up your anxiety as well. There might be distress around how you're perceived by other people, the constant, again, policing that might happen or criticisms that might happen, being worried about going to your doctor's appointment and not knowing what your A1C is, and being worried that they're going to, again, shame you for not having a better A1C. All of those can be quite challenging feelings to sit with. And that I'm just naming minor examples. There's so many examples here that you all, again, may have the lived experience of sitting with that aren't being accounted in even these 7 subscales, because diabetes psychology is still it's basically in its toddler stages right now of development. But again, it's not easily accessible to everybody. Eating distress, similar to what I was talking about earlier with carb counting and so on, that can, again, be something that comes up. Disordered eating or any type of eating disorder. Diabulimia is quite common. There's a number of young folks who've shared experiences with restricting their carb intake or restricting insulin use. That can be something that a psychologist can help with as well. And then friend and family distress, either friends and family focusing too much on diabetes management or too little on your diabetes management. So either over policing or a lack of support. Those are all sources of diabetes distress. So that's what this particular scale can provide information on. And it's a free scale. It's available on the website, and you can just go on and figure out sort of where you might be on some of these, on these 7 subscales that are listed here. And that might also give you an idea of if you wanted to seek out mental health support, what you could talk about with that provider. So as we wrap up, because I know we only have a few more minutes, I wanted to share just quickly some strategies that have been known to actually make changes in diabetes physical health outcomes as well as emotional health outcomes. The first is self-compassion. So recognizing that diabetes it's hard. Just sitting with that idea, I think it can be healing in and of itself. You're not doing anything wrong. There's nothing wrong with you. The idea of having 150 tasks to manage on a day-to-day basis and having to do that day in, day out just to keep yourself alive, that's hard. We just need to sit with that. And allowing yourself that acknowledgement, that level of self-compassion to know that it's okay if there are some days that you may not feel up to the challenge, up to the task of doing everything. And it's okay that you're not going to do it perfectly either. So allowing yourself the compassion of that this is just a hard disease to manage, but it's okay to seek out support. And others are in the same exact boat with you. And the more folks that you can reach out to who have that similar lived experience, or even professionals who you feel like you have a connection to, the easier it'll be for that self-compassion to come through and help you manage the diabetes physical outcomes just as much as the emotional outcomes. Self-talk, self-compassion, and self-talk kind of go hand in hand, but a diabetes psychologist can help you figure out what are the sort of language changes you might need to make in your and how you're talking to yourself about diabetes that might help you feel differently about it. Mobilizing social support, has tremendous impact on healing. Reframing some of the thoughts that are coming up, or some of the messaging that you've received, some of the stories that you've been told that are now feel like absolute truth, but may just be stories or somebody else's projections onto you about how you should be thinking about some of these things. That is a very appropriate intervention. Then acceptance, radical acceptance is the idea that basically you can sit with the truth of diabetes is hard and it's going to take work, and you can do it, but you might need support around it. And how do you access that support is really the point of change. Okay, I don't know if I'm supposed to read the questions myself or not, but I'm just going to go through the Q&A a little bit, and let me know if I'm running out of time. But
we have just a few minutes.
Okay, thank you.
Yeah. Mm-hmm.
I just wanted to say that a lot of you asked in the Q&A box, where do you find a mental health provider that focuses on diabetes? So the main resource that I would share with everybody in the United States, the American Diabetes Association has a mental health directory that lists folks who have a specialty in diabetes for different states. If you go to their website and just search mental health directory, you should be able to find it. I'm on Instagram under Diabetes Redefined, and if you go to my profile, there's a link there, the link tree where you can go to different websites. I link the ADA mental health directory there, so that's one easy way that you can do that. Let's see. So that's ADA would be the best resource. There's a few folks there's about 8 of us on Instagram who are providing, they're generalized conversation points, but I think still important points to be talking about when we're talking about mental health and diabetes. So there's a handful of us on social media. And then let's see, other resources. Sometimes if you go to psychologytoday.com, that's a website where you can find resources for if there's a mental health provider that focuses on chronic illness, sometimes they also have an understanding of diabetes as well. You can access providers in that way as well. Also ask your doctor, your primary care doctor or your endocrinologist, if they don't have resources available on site, definitely ask them to find resources for you. So that's always an option. Or you can go through your insurance company as well. And they would be able to, at the very least, link you up with a mental health provider. And if that mental health provider doesn't have a background in diabetes, they can be a good way to help you identify others who might have the diabetes specialty. Let's see. Other common mental health disorders, yes. So eating disorders, like I was talking about, somebody asked what are the most common mental health disorders that you see. So yes, eating disorders, any type of diabetes and mental health concern that comes up, we have to have a specialist who sees who has that background, because so much of your mood is impacted by your blood sugar levels. And unless somebody understands that from the diabetes perspective, they're not going to be able to, from my perspective, they're not going to be able to really provide you with the best tools that are going to impact your, help you understand how your diabetes blood sugars might be impacting your day-to-day moods, and therefore possibly contributing to other mental health conditions as well. And sometimes it's diabetes distress, and sometimes it's a more significant mental health condition. So you absolutely need a provider who can do that. If you have, I know there's another, there's lots of other questions. If you have more questions, definitely email me. My email is right here. I'm more than happy to answer additional questions in detail, but I know that we're out of time for today. And I'll hand it back over to Eli to take over from here.
Thank you so much, Dr. Nagra. From the chat box and the Q&A and some of the conversation I've been seeing on Twitter, it seems like this was the first time that a lot of folks had learned about diabetes psychology. So hopefully it can be a really exciting starting point for many of the attendees.
Yes.
At this point, we're going to take a short break. T1 International's own Diana Jones is here to help us stretch a bit and relax with a guided yin yoga exercise until 11:30 Pacific time, 2:30 Eastern time, so about 12 minutes. Feel free to come and go in this time, get a snack, do what you need to do, and we'll be back soon with Rosie Collington. Diana?
All right. Wow. Thank you, Dr. Nagra. Since we ran over a little bit, just Eli, feel free to jump back in and stop me if I'm doing yoga and stretching for too long, because I could spend an entire day practicing this activity. So I would say before we actually begin, let's stand up and stretch to make sure that our legs are still there. Still there. Shake them out a bit. Gently shake the shoulders and bicycle your legs. And reach for the stars. And I invite you to come back to sitting. So wherever you are, take a few seconds to get as comfortable as possible and focus on your breath. Inhale for 4. Hold for 4. Release for 4. And again, inhale for 4, hold for 4, and release for 4, 3, 4. Let's do it one more time, and I invite you to close your eyes if that feels right for you. If you're like me, Zoom fatigue is real, and your eyeballs, just like your body, might need a little break. So in for 4. Hold for 4, and release for 4. Great. So, like Eli said, feel free to do what you need to do and what's best for you, but I would like to offer this time as a space to gift ourselves with some short yin yoga postures, all modifiable depending on your level of comfort and whether or not you choose to sit or stand and your needs at this time. So I'm going to remain seated for the duration of my practice, but you can modify any and all of these stretches to give your body exactly what you need. So in my mind's eye, I am going to journey to one of my favorite places, the beach. I invite you to join me here as we continue our practice, or you can take yourself in your mind's eye to wherever it is that you go when you need to find calm and stillness. From what I've heard this morning in the presentations so far, there have been some amazingly deep and profound and challenging things shared. So you might just want to find some tranquility and peace for yourself to process and digest all of the wonderful gifts that this workshop has provided. So in this place, I'm at the beach. I'm going to awaken my senses to the sounds, smells, sights, and tastes, and the feelings of my surrounding. And I'm going to maintain this as I go throughout my seated practice with breaths generally where I go in for 3 and out for 3. That's in for 3 and out for 3. Now, you may already be familiar with yin yoga, which is really about targeting the deep connective tissues between the muscles and the fascia throughout the body. The aim of this type of practice is to increase circulation in the joints and gently improve flexibility, which in turn can help to heal the body by bringing our care and attention and awareness to those areas that may feel tight. Let's begin with our chair, cat, cow stretch. So we're going to sit on the edge of the chair with our spine long and both feet on the floor. You're going to place your hands on your knees or the tops of your thighs. And on an inhale, we're going to arch our spines and roll our shoulders up and back, letting those shoulders drop down. And this is cow. And on an exhale, you're going to arch down into cat. And let's do it again. On an inhale, we're going to arch up to cow. And then on exhale, we're going to come down to cat. If you have any little ones around you, or if you're feeling silly yourself, I invite you on your inhale to come to cow and move. And on your exhale, to come to cow, to cat and mew. So we're going to move now one more time into cow and into cat. It's totally normal if you're hearing some pops and clicks as you do this, but you shouldn't feel any extreme pain. And if you do, just feel free to gently modify what we're doing. Again, the aim of this time together is just to gently loosen up and lubricate those joints so that we have greater sense of ease and flexibility as we move throughout the day. All right, now we're just going to go into our second seated stretch where we raise our hands. So on the inhalation, excuse me, on the inhalation, we're going to raise our arms up. And the exhalation, we're going to drop our hands down. We're going to inhale up and exhale down. As we do this, we want to make sure that we're maintaining good posture, shoulders relaxed, and our rib cage sitting naturally over our hips. We want to feel our sits bones anchored into the seat. Let's one more time go up and down. Great. We're going to go up one more time, and this time when we come down, we're going to let our body fall all the way to the floor. So inhale up and exhale down.
From this position, we want to let our hands rest gently on the floor if they can. Depending on the level of comfort and flexibility that you have in your hips and your torso, you may or may not reach the floor. Wherever you are, that's all right. So let's come all the way up on an inhale.
Up to those stars, sending gratitude and thanks up to the sky, and then receiving and processing through your body as you go back down.
When you find your way to the floor, you want to make sure to let your head hang heavy. And let's go up one more time. Inhale up.
And exhale down.
When you're down there, feel free to let out any tension or tight spots and thoughts that may have gotten trapped in there while we were processing
and taking in all of the generosity that our panelists have brought to this presentation. All right, now let's move into a chair side angle pose. So this time we're going to go up, and I'm going to slowly bring both hands down, but I'm going to leave my left hand down by the left side of my foot.
I'm going to twist from my torso while my sits bones are planted on the chair, and I'm going to lift my arm up to the sky, opening my chest, lengthening my spine long, and allowing my neck to move freely and easily as I find myself able to take in a whole new perspective. Think about it. How often do you really let your body twist and turn and open up in this way? And I'm going to exhale my right hand down. So now both hands are on the sides of my feet. I'm going to come all the way up. Roll my shoulders back. This time I'm going to lift my hands up and I'm going to bring my right hand down to the ground. And I'm going to exhale down. Right hand comes to the right outside of my right foot as I lift and twist my left hand up to the sky. Really see if you can gently allow space and breath into the sides of your body, into your sits bones and the back of your neck and your spine, all these areas that I at least know for me, I often find I crunch and keep tight because there's some sensitive feeling spaces. I'm gonna let my left hand come down to the floor and I'm gonna slowly roll back up and shake my shoulders as I find myself back in my seat. All right, let's move on one more time to the chair pigeon pose. All right, so I would say so far we've spent a fair amount of time focusing on opening up our chest and our upper bodies, but we've got these important things right here called our legs. And to make sure we maintain a connection with our legs and the lower parts of our body that keep ourselves grounded, we're going to do a chair pigeon. So I invite you again to whatever degree of comfort you have to bring your right ankle on top of your left thigh and keeping your knee in line with your ankle as much as possible. Notice the triangle shape that we've created. Triangle is the strongest shape I hear, so notice and take in, if anything, the thought that you can create triangles, strong shapes with your body. And as we feel our sits bones on our chair, our shoulders over our hips, and our ears over our shoulders, if you have any experience of feeling more grounded in your own sense of self and power in this position, we inhale our spines long, and if you'd like, lean your spine forward, keeping your sits bones on the chair and allowing your spine to lengthen. Create height out of the top of your head. Nod your head, yes. Shake your head, no. Nod your head, yes. Shake your head, no. And come back up. Looks like we might have time for just our left leg. So let's bring ourselves into the chair pigeon on our left side. So left foot up onto the top of your right knee. Again, notice the triangle that you've created on the left side with your sits bones planted firmly in your chair, your shoulders in line over your hips, and your ears in line over your shoulders, creating a nice lengthened, easy passage for breath, sound, and energy to move. We inhale up and exhale, roll the shoulders down in your seat of power, embracing everything that you can create when you take full ownership of yourself. Inhale up. And if you'd like, lean forward gently over your left side. It's completely normal if one side is tighter or, a little more flexible than the other, but just notice, no need for judgment. You are where you are. So inhale up and roll your shoulders back, exhale down. So I see that it's 11:30, but unless someone tells me to stop, I'm just going to keep doing my yoga because I have one of my favorite poses left. I guess we can end with this one. The eagle arms, where you either bring your arms, two arms out, and you bring your right hand over your left hand over your right, and your palms together, your fingertips into your palms. Lift those arms up to the sky. If this is not accessible,
to you, I invite you to, Eli, I feel like this is a great place to end. Simply give yourself a hug.
Thank you so much, Diana. I feel like at the point in the day I needed a hug. So that was a really lovely ending, even though I'm really so flexible as you. So thank you so much, and welcome back to everybody. Our next session is with Rosie Collington. We're going to have a look into the financialization of the insulin industry. Rosie is a political economist researching relationships between health innovation governance and patient access. She joins us today from Denmark. And just so both Rosie and our audience are aware, we will be turning the chat feature back on for this presentation. Welcome, Rosie.
Yeah, wow, thank you, Diana. That was amazing. It's not very often you get to start a presentation doing stretches, which we all need, working from home at the desk. But yeah, it's a huge honor to be here and to be part of this event and to share with you this presentation. You know, I'm a huge supporter of T1 International and everything you do. So thank you so much for having me. I'm an incoming PhD student at University College London in the UK. And I'm also a researcher with the Academic Industry Research Network, which is based in Cambridge in Massachusetts. And I'm here today to tell you a bit about some research that I've conducted with colleagues on the corporate governance of the 3 dominant pharmaceutical companies that manufacture analog insulin. I'm sure I don't need to tell you who they are. It's Eli Lilly, Novo Nordisk, and Sanofi. And so specifically, our research has sought to understand what the relationship between shareholders, list price increases, and the way the companies have distributed profits from insulin sales is. We think that analyzing the ways that profits are allocated by a company can tell us a lot about what drives drug list price increases. So this is quite an unorthodox way to start a presentation, but I know and understand how tiring Zoom workshops can be, even when they're as brilliant as this one. So I'm going to try and grab your attention early with a quick game, and you're able to take part in that in the comment box. So to get going though for this presentation, I just wanted to make sure that everyone understands what we mean by shares, as they're quite important for what I'm going to discuss and also for this game that we're about to play. I'm hoping everyone knows or has an idea of what a shareholder is. So it's literally a holder of shares in a company. Corporate shareholders can include institutional investors, pension funds, and wealthy individuals. Companies basically sell shares as a way of accessing financing, and a share basically entitles the holder to a share of future profits or losses, and also some kind of influence or control over the strategy of the company. Shareholders benefit from shares in 2 ways. The first is through cash dividends, which are paid out today kind of as a yearly reward or as a thank you for holding the share. Though once upon a time, they were really just tied to the profits yielded by the company or their losses. The second way that a company can extract value, or that a shareholder can extract value from a company, is through something called share repurchasing. And this is where a company buys back their own stock from the market. And this share repurchasing can benefit company insiders, like executives who are often paid in shares, because they can decide to time when they sell their shares to get the most value. The game that we're going to play is a version of something called higher or lower, and the rules are quite simple. So together you need to guess how much the 3 insulin or analog insulin manufacturers together, so that's Eli Lilly, Novo Nordisk, and Sanofi, paid out to shareholders through cash dividends and share repurchasing in the 10-year period 2009 to 2018, as the list price of analog insulin in the United States soared. So I'm going to show you a value on the screen, and then you need to write in the comment box whether you think the amount that that was distributed to shareholders is higher or lower than that amount. So yeah, maybe let's make it easy to begin with. Maybe, hopefully, do you think that the amount paid out to shareholders in this period is higher or lower than Apple's current market value of $2 trillion? a second, I'm having some, okay, I can't see my comments actually. Give me 2 seconds. I knew this would happen. Okay, yeah, so, sorry.
No, I was gonna say, it looks like most folks are saying lower.
Okay, great, thank you. Yeah, so exactly, it is lower. And how about the average cost of insulin for 1 year for one patient in the United States in 2016? So a lot of people, as we know, did pay more than this. Do you think the amount distributed to shareholders was higher or lower than that? Yeah, much higher, much higher. How about the asking price for a condo in Trump Tower? So that was $3.1 million, at least when I looked, according to Google. Yeah, so it's much higher than that. And how about the value of Buckingham Palace in London, which apparently is valued at $5 billion. I didn't know that before I looked that up for this presentation. It's much higher than that as well. How about the worth, so the net worth of the richest man in the world, Jeff Bezos, who many of you are probably familiar with. So he's currently worth, after coronavirus crisis, $196 billion. Okay, so right now, it is lower, but when I gave a similar presentation about this data just a few months ago, in April, it was exactly the same amount actually. So Bezos has made quite a lot of money during the coronavirus. You might have read about that in the news. But so the amount that the shareholders, that the three insulin manufacturers distributed to shareholders between 2009 to 2018 was $122 billion, which is quite a lot. Recently, a guy on TikTok called Humphrey Yang made a video to try and show the difference between $100,000 and $122 billion that I think helps to put this number into perspective a bit, because it is really big and it's kind of difficult to get our head around. But the rest of this presentation will really try to help to put that number into context a bit and show why it's been important as well for pricing in the United States. Just very quickly before we do that, I thought I would tell you about how and why this research came about. So I'm talking to you today from Copenhagen, where Novo Nordisk, one of the big three, is based. And before moving to Copenhagen in 2018, I had worked for a few years in policy at a few UK-based patient organizations, doing some work on drug approval processes for orphan drugs, amongst other things. So I was fairly familiar with the pharmaceutical industry. And here in Denmark, I started noticing how prominent this company, Novo Nordisk, is. You know, it was funding huge amounts of medical research at universities through a foundation that it has. It's the country's third largest company and a huge employer. When I had a blood test, there were Novo Nordisk branded folders in the nurse's office, which is something we never see in Europe. It's very rare. But more than anything, what was interesting to me was how fondly Danes speak about Novo Nordisk as this kind of really innovative, responsible, environmentally friendly company. So I started to think, or maybe Novo Nordisk, this company does hold the key to kind of good pharmaceutical governance. Maybe this is a good pharmaceutical company. How different is it really? So yeah, I'm quite embarrassed to say now that, like many Danes and many people, that at the time I had no idea how big Novo Nordisk is in the insulin market. This slide is taken directly from an investor report by Novo Nordisk. So that's the information that they give to shareholders. And as you can see here, Novo Nordisk is actually the biggest company in terms of its share of the analog insulin and wider diabetes markets, putting that in air quotes. It relies on sales of insulin products in the States for over 40% of its total sales revenue, and 80% of its sales come from insulin and its wider diabetes line. So I knew there was an insulin crisis in the States when I first started looking into this company, but I still hadn't put two and two together until I started analyzing the company's financial reports. And now, just to be really clear, and as this presentation will show, Novo Nordisk and even the other manufacturers are not solely responsible for insulin list price increases in the United States, but they do ultimately set the list prices, and they're a really important actor. So my research with Professor Bill Lazonick focuses on the corporate governance of the insulin manufacturers, because we think that by understanding where the higher profits from insulin sales have gone as the list prices of insulin products have increased, we can understand what is driving those price increases. So we ask, who benefits when the price of insulin increases? Is it solely intermediaries like pharmacy benefits managers, which is a claim that is often made, or do the manufacturers also get some of the profits? And then what do they do with those profits? Do they invest them in research and development to develop new drugs, or do they just distribute them to shareholders? And I wanted this presentation to not just be informative, which I hope it is, but also hopefully useful. So I'm going to frame the rest of it in terms of 3 really common arguments that are made against regulating insulin prices in the United States. So you can use the actual data from the actual company reports in your activism and organizing. So these 3 kind of core arguments that we hear quite a lot are, first of all, that manufacturers haven't benefited from list price increases, so it's the intermediaries. Second, that high prices are needed to fund research and development in new drugs. And thirdly, that manufacturers' profits are just compensation for their earlier drug development. So the first argument is that manufacturers haven't benefited from list price increases. To begin, our analysis of the company's financial data look to establish whether these manufacturers have actually seen increased revenue from insulin sales as the list prices have increased. And this is really important to establish because, as you probably know, the manufacturers and kind of wider industry claims have been that they haven't benefited from list price increases, that this additional revenue has in fact just been captured by intermediaries in the supply chains like pharmacy benefits managers. Now, it's indisputable that a huge chunk of the value of insulin product list prices is captured by these intermediaries. Like, no one is denying that. And it's important to recognize that these intermediaries have a really big stake in list prices increasing. The amount returned to intermediaries is based on list prices, and list prices have soared at a far higher rate than net prices, which is the amount that is returned to manufacturers. We don't focus too much on these intermediaries that you can see here in our research, really because a lot of attention has already been paid to these actors, even though it's ultimately the manufacturers that ultimately set the list prices. If anyone is interested in finding out more about these intermediaries, there is a really great book by an academic called Robin Feldman that's nice and accessible and explains everything really clearly that I can recommend. But in any case, we found that manufacturers' revenue from insulin products also increased in the 10-year period between 2009 to 2018, meaning that they also benefited from price increases. So we found that their annual net revenue from insulin products across the 3 companies was on average $6.3 billion. So that's 44% higher than 2009 for the years 2010 to 2018. So that's quite a big difference, and it was driven primarily by revenue increases in the United States. I realize that some of you will already kind of know some of this stuff. Some of you might have seen some of this data on Twitter, for example, or you might, or most of you probably have guessed that this is what's happening, and I kind of recognize that it can be quite difficult to hear. So I can't see any of you, but I hope everyone's doing okay. As we were doing this research, a really important paper was published by some researchers at the University of Pittsburgh, which also showed that net prices, so the amount returned to the manufacturers, had increased by 51% in this period. So that kind of supported our findings. So now we know that the companies have seen higher revenues from insulin. How have they actually distributed these higher profits? A really common argument that we hear all the time from not just the industry, but also researchers and neighbors, family members, doctors, is that these higher drug prices are what funds future drug development. Drug price increases, we are told, are needed because the costs of developing a medicine have increased. Now, it's true that getting a completely new innovative drug to market is a lot more expensive than it was, say, in the 50s. But across the wider pharmaceutical industry in the United States, we see from the company's financial reports that these huge profits that the companies make are not, in fact, primarily being allocated to research and development. So my research colleague, Bill Lazonic, and others have done extensive research on this that shows that, in fact, an increasingly higher proportion of profits across the biggest pharmaceutical companies in the United States have been returned to shareholders. And unfortunately, as it turns out, it is also true in the case of insulin manufacturers. So in these 10 years, as list prices grew, the amount that was actually allocated to R&D relative to the amount distributed to shareholders actually decreased. And even if companies had used the profits in this way, it's also important to push back, as I'm sure most of you do anyway. It's important to really push back on this quite well-established idea that it is patients requiring a medicine that should be footing the bill for future innovation. Why only patients? Why only those of us with chronic diseases? Why aren't these costs shared between everyone? And the final argument is that these higher prices are a retrospective reward for the development of these drugs that occurred earlier on in their life. So this line, it has been even put forward by insulin manufacturer executives. So Novo Nordisk's North America Chief Medical Officer argued in 2017 that while the leaps made in newer insulins may not have been as significant as developments in earlier insulin formulations, and he said, and I quote, "If you look at the advancements from where we were 25 years ago, it's been considerable." So the argument, this argument assumes that it is the manufacturers that bear the greatest cost of developing a drug simply because they are the actor that holds the market exclusivity rights for it. But history tells us that this isn't the case for most medicines, and it certainly isn't the case for insulin. So researchers at Bentley University in Massachusetts identified, for example, that every single one of the 210 new drugs approved by the Food and Drug Administration, the FDA, in the United States between 2010 and 2016 had received funding from the National Institutes of Health at some stage in their development, worth in total, so this funding was worth in total more than $100 billion. Today, the National Institutes of Health, using taxpayer funding, remember, invests $41.7 billion annually in medical research. So really, it is us that is funding, it's taxpayers and us and the public that is really funding the development of these drugs. And governments have borne crucial risks throughout insulin's development as well. From the early work of Banting, Best, Collett, and McLeod that I'm sure a lot of you will be familiar with, that led to the first use of insulin as a treatment for type 1 diabetes in 1922, to the development of recombinant DNA, which was used in to develop the world's first human insulin. Today's insulin formations owe their evolution in no small part to public institutions and investments across the 20th century. So this is probably a bit heavy for some of you. As I said before, I hope everyone's doing okay, but there are possible solutions to this. The way that we develop drugs, the way that insulin and drugs more widely are priced doesn't have to be like this. These are social institutions that we should be able to change, and hopefully we can. Fundamentally, it goes without saying that we need a system where everyone who needs a medicine can get access to it. where patients don't need to sell their house or their car or move abroad or risk their life trying to get access to the thing they need to survive. I'm pretty sure everyone here can agree with that, and actually most people do, which is something we can be optimistic about. But in remaking this system, we can also establish new modes of drug innovation that actually help patients in the end, and not just shareholders and the corporate executives who I've discussed during this presentation. So some solutions of what that kind of new structure could look like include a public manufacturer of insulin, which could be established, that produces analog insulin, which, you know, these products have really existed in their current form for 25 years now, to ensure no patient who needs it goes without their prescription. These manufacturers could exist at the state, municipal, or regional level, and this has been proposed in more detail elsewhere. So I can send some links to that if anyone's interested in reading about some of those plans. But in the absence of this, our second proposal would be for price caps to be introduced for insulin, as exist in the majority of OECD countries, and have been introduced or proposed in some US states as well. And price caps are not necessarily the way of transforming the system in the system of drug development and provision in the long run, but they would of course improve access for patients, and also undermine this kind of warped flow of payments that exist in the supply chain that allows all of these intermediaries to access and extract profits on the basis of list prices. And finally, you know, we need reform of corporate governance rules to limit these stock buybacks and cash dividends, at the very least, when decisions can be shown to bring harm to citizens, as when executives increase list prices in ways that limit patient access. A final and I guess more radical idea that I will finish with would be regulating how the companies spend their profits and price their products altogether. So the whole system, which is something that we're certainly starting to think about in our research. I think we have a couple minutes left now for question and answer, but I knew I was going to go over time a bit, so I've also left my email address and Twitter account, and you should feel free to get in contact with me on there if you have any other questions about the presentation. But thank you so much for having me.
Thank you, Rosie. I think we have a few minutes here to take some questions. So if anyone, I see there are a couple questions in the Q&A already. If you have a question and we have time to get to it, then we'd love to have you for a few more minutes here. Just to quickly begin, the book that you had mentioned, was that Drugs, Money, and Secret Handshakes, The Unstoppable Growth of Prescription Drug Prices?
Yes, it was. Yeah.
Thank you. So going to the Q&A box for a couple of questions here. Eric asks, why in America can pharmacy benefit managers, PBMs, drive prices so high, while in other comparable countries they may not have that issue? Or do they have that issue?
Yes, so I mean, you're completely right. The system that exists in the US, not just for developing drugs, but for accessing drugs, is very different to systems that exist basically everywhere else in the world. Pharmacy benefits managers, PBMs, originally developed in a way or to serve a purpose that could arguably be in patients' interests. So they were originally emerged as a way to help health insurance get or kind of negotiate prices in the interest of health insurance and in the interest of patients. That's kind of how they emerged. But they've become this really concentrated sector. So that means that there's very few companies involved, and they now have huge leverage over the price of drugs. Why that system exists in America and nowhere else? I mean, it's a good question, and we would argue now that we can't see it through our research where pharmacy benefits managers in particular actually add value. So what are they actually doing for patients now? What are they doing for health insurance companies now? Like the purpose that they were originally developed to address, or the challenges that they were originally developed to address, they're not serving that purpose now. So what are they doing? So it's a good question. I have a personal opinion that they do not currently serve a purpose.
I think in a lot of aspects, not serving their original purpose is a continuing theme in this area. So Louise asks, what will be the ways to push for public manufacturing of medicine outside of the US, especially in Europe, where most people have access to free insulin, even if the social states are paying a high price to big pharma as well?
I'm just going to read the question. So there was a really good paper published, a kind of policy paper that was developed with some patient groups in the US and some of the Medicare for All campaign groups last year by, I will share the paper with you later on, by someone called Dana Brown, and it basically offered a kind of blueprint for how these manufacturers how these manufacturers could be established. And the idea behind this was that for drugs where they have existed for a long time and they have a huge kind of patient base, then there's no reason why they shouldn't be a public manufacturer for them other than the kind of IP infrastructure that exists at the moment. I think there is a movement already that is calling for that, and I'll try and share some links at some point with this audience, and then hopefully you can read more about what's happening there with the public manufacturer push.
Absolutely. Thank you for sharing that. Dana's paper is incredible. It's just a really excellent report. So I saw that Jen had asked, is it true that distributors contribute to the high cost of insulin to patients?
Yeah, and this is something that Robin Feldman explains very clearly in her book, that basically, so Robin Feldman wrote the book, I can't remember what it's called now. Eli, you just mentioned what it's called, but Robin Feldman wrote a book about how all of the intermediaries in the supply chain for accessing medicine in the United States basically serve to benefit from list prices. So distributors as well are not as we don't think they're as significant as pharmacy benefits managers, for example, and they don't set the list prices. So it's the manufacturers that set the list prices, but distributors benefit from high list prices and therefore serve to benefit from it.
Yeah, absolutely. Everyone gets a little piece of the broken system, except
exactly, yeah.
So I think we probably have time for one, maybe two more questions. So Elizabeth asked, and we may need more than 2 minutes to talk about this one, but we'll try to keep it brief. This is complex, but I wonder, would eliminating employer-funded health insurance help to lower the price of insulin?
I wonder, would eliminating employer-funded insurance help? I'm not sure that I'm best placed to answer that question. I think fundamentally, if employer-funded insurance didn't exist, then under alternative systems, we may similarly see high insulin prices owing to the other kind of wider challenges that exist in terms of value extraction by the manufacturers, by the range of intermediaries that exist. So that was what I was discussing earlier. So I'm probably not best placed to answer that question, if I'm honest, because I'm not an expert on the different insurance schemes that exist in the United States. But I would say that if all of these wider things remain in place, then I imagine, or I anticipate that unfortunately it probably wouldn't change it significantly.
I think that question actually gives us a great opportunity to lead into our next speaker, who's going to be talking about some of the power dynamics that are present in the market for medicines such as insulin that people rely on to survive. So Rosie, if you don't mind, I really appreciate the talk that you gave today, and thank you so much for sharing. We'll make sure that folks have Rosie's email, which she had posted on that slide, so that you can reach out with all the great questions that we've gotten. I apologize that we didn't have a chance to get to all of those right now. But Rosie, thank you again so much.
Absolutely. Thank you for having me, and enjoy the workshop, everyone.
Hopefully. So next we have, we're going to be hearing from Priti Krishtel, who is the co-founder of the Initiative for Medicines, Access and Knowledge, and a veteran of the Global Access to Medicines movement. In her work, she exposes how the failures of the patent system are affecting all of us and how we can fix it. Priti will also be taking questions from the audience at the end of her presentation, so please feel free to enter your questions in the Q&A box, and Priti will answer as many as our time allows. Thank you so much for joining us.
Okay, well, I'm very honored that you all asked me to join you today. I know that it has been a really tough year We came into this year thinking we were going to get to do so much activism and finally be heard on the high cost of drugs. And then COVID happened, and that's caused all of us, I think, to have to expand and pivot and rest. And we're now having a long overdue racial reckoning, which is adding, I think, much needed dimensionality to so much of our work. And so I was asked today to speak about the drug patent problem and how more activists can join this fight. So I'm going to focus my comments there. And I'm going to do it in 3 parts. First, I'm going to share my story of how I came to this work and why I've chosen to focus on patents. Then I'm going to go into some diabetes medication case studies to illustrate how patents play a role in the high cost of drugs. And then I'm going to end by offering some advocacy strategies that you all might want to, or frameworks actually for thinking about advocacy strategies that you all may want to consider as you embark on your next chapter. So with that, about 20 years ago, came to this work. When I graduated law school shortly thereafter, I moved to India and I worked for an organization called the Lawyers Collective, which is a human rights NGO working with people living below the poverty line who couldn't afford their medication. And one of my very first clients, I was asked to set up an office to service South India. And I was running a team of 10 to 15 advocates, community organizers, and legal aid lawyers. And one of our very first clients when we set up the South India office was a family of 5, a mother and father who were at the end stages of having AIDS and knew that they weren't going to make it because even though the medicines existed, they weren't reaching most people in the global South at the time. And so they had come to our office to ask us to draw up adoption and guardianship papers for their 3 children. And it was really heart-wrenching for me as an American working there at the time to realize I was an HIV counselor here before I went, and I realized that people here were able to get the medication and people there weren't. And this family was literally going to be separated just because of the high cost of drugs. And so that was what started to really build my passion for this work, that really no family should be separated because of the way that medicines are priced. And shortly thereafter, I co-founded IMAC with Tahir Amin, who's still my co-founder today. We unpacked this problem, and there are so many ways that drugs are priced, as you just heard in the last presentation. There are so many drivers for the high cost of drugs. And maybe this is because we're lawyers, but we really honed in on patents as one of the root sources of the power to price. And so we came to this work, and we still do this work so many years later, because we think that, my colleague Rohit, who used to work for MSF, used to say, intellectual property rights, which includes patents, are the new currency. It's like money, it's like big data, it's like oil. It's become this new form, this new asset that drives capital flows and it drives power, but nobody talks about it. And I think that's the reason why many of us choose to focus here and why we founded IMAC, is because we believe you have to go to those root sources of power if you want to dismantle them and if you want to make change. So after we started IMAC, one of our very first cases was the Positive Women's Network in India. They had come to us to talk to us about pediatric nevirapine, which is a form of an HIV drug that they needed for their children. And they asked us to look into the patent side of this problem. Our team is basically, we jokingly call ourselves patent detectives. So we started to look under the hood to investigate the patents on this particular medicine. Now, the way patents are supposed to work, they are a right that the government gives. So if you invent something, the government gives you a piece of paper that says you got the patent, that basically gives you a 20-year monopoly, during which time nobody else can make or sell the drug. But as we started going through not only for HIV, but for so many drugs across diseases, we started to realize that drug makers were basically gaming the system, that they were filing dozens and dozens and dozens of patents on any given medicine. And so we decided that we wanted to figure out how to stop them. And our team had come from the private sector. Our lead scientist used to be an executive in the pharmaceutical industry. And Tahir had spent years working at law firms on the other side of the fight. So they were like, we need to go in using a legal route and challenge pharma on its own terms. And so what we did was we started to hunt for what we call the blocking patent. And this is the patent where the company is so obviously just filing these frivolous follow-on patents so they can make their monopoly longer. But if you challenge it and you win, you can shave time off of the length of the monopoly. And so that's what we did in this case. And we were able to break the patent by filing, basically, it's like a litigation. And you file it and you say on scientific grounds, it's not on ethical grounds though, so it can't be about drug pricing, but on all these scientific grounds, and you make these legal arguments, you can say this patent application is not inventive, or it's not new, or it's not useful. And if you can prove those grounds, then you break the patent. So that's what we did. And then over the years, we did that on many cases, and many civil society organizations have done this work all over the world. This is actually an old slide. I would say that based on the most recent estimates, civil society has now, we've enabled closer to $50 billion in cost savings for health systems across the global south. So this is a major accomplishment where, you know, just a few people on their laptops in different countries are doing this work, and we've seen huge success. So then in 2015, we were asked to come to the US because obviously the US is in a drug pricing crisis as well, which there are many drivers for that crisis, but one driver is that the patent system is not working as intended. And so when we got to the United States, remember, it's supposed to be one invention, one patent. But on medicines, because there are different components that go into a medicine, or for many other reasons, drug companies are filing so many patents on each invention. And so we decided to do an investigation this is back in 2018, to say, well, how many patent applications are they filing on the best-selling drugs in America? And what we found, I'm going to show you what we found in 2018. There were seven. There's seven I'm showing you here, which includes one diabetes drug. But on average, what we were finding is that there were 125 patents being filed on each of the best-selling medications. And there were 71, if I recall correctly, granted on each of these drugs, which was crazy. So we put out this investigation that said, look, patents are supposed to be for real inventions, but this is the kind of gaming we're seeing in the system right now. So a drug company is supposed to get 20 years of monopoly, during which time it's the only one that can be on the market. But we're seeing that number as of 2018 is now 38 years. So the monopoly life is doubling, and we're not getting competition and prices aren't coming down. So for things like insulin, we put out a report and we partnered with T1 International on this. You know, we were able to show that this is a serious problem. This is one of the drivers that's causing companies to have a longer monopoly. And I'll show you what we found next, but basically, like, they're able to start hiking their prices as they get closer to patent expiration. So at this time, you know, when we entered the US between 2015 and 2018, we thought, well, we've litigated all over the world, so have our partners, like, let's go do this work in the US and show them, you know, how we as the Access to Medicines do this work. And this is what happened to us. The United States Patent Office is not friendly or welcoming to civil society getting involved in patent discussions. In fact, I would say, as you all embark on this next chapter of work, I would go so far as to say the Patent Office and the patent system and the people who act within it in the United States do not actually believe that patents and prices should be connected. Patents are there to reward innovation. You know, if you talk to any of them, that's what they'll say. Somebody else prices it. Somebody else decides how it's going to get to real people. That's not our responsibility. We disagree strongly with that statement. We think that patents absolutely have to do with pricing and patients, affordability and access, because they provide the power for manufacturers to be the only ones to sell. And so what we learned in our own experience is that we did not think and do not think that strategic litigation should happen without public pressure. And so these are the years now where we start to elevate the issue of patent abuse, where we start to put pressure on Congress, on the USPTO, on other key actors to say, we need to do something about the drug patent problem. So here I'll just dive into a couple of quick examples to illustrate the issue. And if there are questions, I'm happy to answer them, although my focus will be more on the patents, less on the pricing of these drugs. So in 2018, I mentioned we did these investigations because the price had increased so significantly between 2012 and 2018. And we knew from our partnership with folks in this movement that people were not able to afford their insulin. We found that on Lantus, the 20-year monopoly should have ended, but instead, on the first patent, but instead there were 46 additional granted patents, which pretty much doubled the monopoly life of the drug. And what was interesting about this is that the argument you would get from industry is that, well, that's invention, we have to do R&D. But FDA approval of a drug does not happen for several years after you first, early on, you file your patent. And what we were finding is the vast majority of patents on Lantus, but also on a lot of the best-selling drugs, happen after FDA approval. They happen when a bunch of people working at law firms realize this monopoly period that we have is going to expire. Other people are going to enter the market. The price is going to have to come down. We need to make as much money as possible for as long as possible. So they build these patent walls. Now, it's worth noting that the US has more applications on many of these best-selling drugs than other high-income countries. And that's not to feed the nationalist sentiment that's happening in certain circles right now in the country to say that other people are free riding. That is not what I'm saying. What I'm saying is that drug makers have found a way to actually exploit and weaken our system, and we need to focus on that, target it, and fix it. Another example is Humalog, which many of you are familiar with. The price of Humalog, as I'm sure has been discussed probably already, it increased at 10 times the rate of inflation over the last decade. And one of the things we found very interesting when we started to look into the patent portfolio of this is that when the 20-year mark ended, there were still so many patents that had been filed and granted. So now you're looking at not just what we said in the 2018 investigation, which is that the monopoly length of drugs is almost doubling. What we're finding now is that it's more than doubling because the protection on Humalog is now at 46 years. And there are still, for all of these drugs, more applications being filed. Now, I do want to acknowledge that the price of Lantus and Humalog came down this year after COVID hit. And I think that's important, but it doesn't correct for the underlying structural issues that many of these drugs that we're looking at, they shouldn't still be on monopoly to begin with. So I just want to name that. And so in my remaining time right now, I wanted to move into what does patent-related advocacy look like? We put a framework out earlier this year, and we're hoping over the next year, including in collaboration with you all and many others, that we're going to start to color or put the paint on the canvas around this. After many years of doing this work, we've identified that there are 5 basic pillars that we call RAISE that have to change if we're going to correct for the inefficiencies in the patent system, start to dismantle some of the structural inequity, and start to build something new in its place. The first is raise the bar, which would address this over-patenting problem I've been talking about today, where when you raise the standard for what gets a patent and is considered an invention, you'll do a lot to shorten monopoly life and bring drug prices down. A stands for amend incentives. What we found in looking at this system is that all of the actors in the system, whether it's patent offices, patent examiners, pharmaceutical companies, every actor doesn't quite have the right incentives that we would want to see to bring the change we want. Increasing participation is very straightforward, and I'll talk about it more in the next slide. But currently, the US Patent Office and the patent offices in many countries are still a black box. It is there to serve companies and inventors to invent and to then, by extension, bolster economic growth based on current economic ideology that says you need a lot of innovation, therefore you need more and more patents. And so they do not believe actually that meaningful public participation is important. And I'm happy to send you some writing that I and others have done on this at a really high level, but we know that this is wrong. When a system affects people who take medication have to be involved in that system at every step and have to be meaningfully included, and their inputs have to shape how that system evolves. This does not happen at all. This is what I see as the Insulin for All movement's primary next chapter contribution, if this is something you all decide to take on. And standing for justice, the next one, the letter S, basically is in line with that. Currently going to court, so not just participating at the patent office level, but also to get justice, to be able to go to court or to be able to go to the patent office trial and appellate board. There's not easy ways to do that. It's very expensive. Oftentimes we don't have legal standing to go to court. And so this is an area where I think we have to demand inclusion, participation, and justice as well. And then lastly, expanding oversight. There's virtually no oversight of the patent system in the United States today. And so this is another fundamental area for intervention. So that's the what. I want to say just a couple of things about the how. I believe that communities have to lead the process for defining advocacy strategies. So I am not putting out a roadmap on this. What I want to offer are 3 frameworks for how you all could think about it. The first is, I think that there are many, many, many people across the global South, and we stand on their shoulders to do this work because there have been people doing this work now for 20, 30 years. I think we, those of us who are starting to engage in this work in the United States, we have so much to learn. I get some pleasure in thinking about this would be our way of decolonizing global health, is to call on many of those folks as our teachers and start to get trained up in what strategies have patient-led movements in other countries been doing. And I know you kicked off today's workshop with a little bit of that. On the patent issue specifically, there's so much to learn. There has been such depth and breadth of experience. So I think that would be a good starting point. The second is engaging in legal mechanisms. I think one of the first steps for this would be to start to identify movement lawyers, not just legal practitioners, but people who are going to be with you for this long ride, people who are committed to community-led processes. And I'll give you a tip here from my own years of being a movement lawyer, is that it's really important for community to hold lawyers accountable. I think that oftentimes as lawyers, and I'm speaking about myself now, I'm not pointing the finger at anybody else, we get in our heads and we get so caught up in our struggles for justice, and we have all these ideas about how we can do the work. And we shift from being servant leaders to trying to lead the process. And in that moment, I would say this is the most important part of setting the foundation as you start to think about how to engage in legal work on this issue in the US, is defining that relationship, being really clear that as community, as the movement, you're going to set the strategy. And what you need from your lawyers is to be educators, to be translators, to be true movement lawyers. And there's great work that's been done on this to like define what that looks like, that I think would be really valuable to start with. And then from there, you can think about litigation, you can think about administrative office actions, like at the United States Patent Office itself. You can think about filing amicus briefs, which might be a great place to start. But I would make sure the foundation is set right first. And then lastly, I think in the next 3 to 5 years, we're going to have to educate people about this problem. Patents are not something that's talked about in the United States. I think there's a lot of incredible work to do. I think when I think about my own organization and what I'd love to see us achieve in partnership with your movement and others in the next few years is, I think we need to make sure Congress has hearings on the patent problem. There's been some drug pricing hearings. This Wednesday and Thursday, they're going to call in the big pharma CEOs, although I don't think the insulin manufacturers, but they're calling in the pharma CEOs. They're going to probably talk about patents, is my guess, based on the subpoena they just issued to AbbVie. It's not enough. We need to have meaningful patient participation. We need to have congressional hearings. We need to have PTO holding hearings and roundtables where they give patients and communities a seat at the table. And we need the media covering these stories a lot more. And so I'm happy to come back and brainstorm with you all, but I think this is a good starting point to thinking about where the intervention points are. And then one last thing that I wanted to say before wrapping up is that this Wednesday and Thursday, we're getting a pretty rare opportunity because the Congressional House Oversight Committee in the US is going to call the pharma CEOs in. I recognize that it's probably not going to focus on diabetes medication, but to the extent that it will focus on some of the structural levers, including patents, I think there's a lot you all could do by following and amplifying and commenting on what Congress is doing right now. My colleague, Tahir, who's the last Twitter handle here, as well as IMAC Global, are going to be following the hearings and really elevating some of the key points around drug patents, driving some of the pricing problems we're seeing today and some of the access problems we're seeing today. So if you also wanted to amplify them, that would be amazing as well. And that's it. So if you all have any questions, I'm happy to take them.
Thank you so much, Priti. And yeah, it's a really exciting opportunity coming up in Congress this week to hold some of the pharmaceutical manufacturers accountable for their more egregious practices. So I believe we've got about 10 minutes in the schedule here for questions. So if anyone has questions, please feel free to use the Q&A feature in Zoom to ask those. The first one that I see here is from Louise, who asks, which part of the process is still under patent? Because the compound Gaudin is off patent since a few years ago in the US. So if you happen to know what the drug companies still have patented, that may be interesting to folks.
Oh, that's really interesting. I don't know. Our legal team would know, but I'm happy to send over the information.
Cool. Thank you so much. So Jessica has another question. Where do you think the best source of patent reform would stem from? Is it regulatory action? Would it be legislative action? Would it be judicial action?
Unfortunately, I think that it depends on the issue. I showed you the RAISE platform. There are opportunities to use all three of these. So for example, regulatory action could address some of the problems we've been seeing in the last couple of years around public intervention at the USPTO to challenge patents. Judicial action could rectify some of the long-standing issues we're seeing in how patents are implemented. But standing is always going to be our barrier there. There have been so many, and I think this is a really interesting story, which maybe we could spend time on down the line, but the ways in which public interest groups, from farmers to breast cancer patients, have tried to intervene in the US patent process and not been given, the right basically to participate in court proceedings, does not give me a lot of optimism that we will be that successful there, unless you can meet the standing requirement that you were directly harmed, essentially commercially, and could be sued by the manufacturer. So there's some interesting creative space that you all could think about playing in there. So unfortunately or fortunately, by statute is going to be the big win. It's going to take a long time, but I think there are a lot of things that we can do along the way to get pieces of it passed in bills that are passing for other things. And so one of the things we saw in the last few years, since we put out over patented and some of our policy recommendations, we saw more transparency bills get tabled on this issue, more awareness in the policymaker community that that transparency around small molecule and biologic drugs was going to be a key barrier to bringing drug prices down. And so I think bit by bit, we can start to get things introduced in bills, but ultimately raising the bar for what gets a patent is going to be probably one of our biggest fights. And that's where I think it's going to have to be done by statute.
Yeah, there are a lot of opportunities to pass legislation that would challenge the patent problem head on, and Congress hasn't gotten there yet, but I think there are probably some hopeful signs in that direction. So I see that Elizabeth, oh, I'm sorry, go ahead.
Let me just say one more thing about this. I think, in the access to medicines movement over time, we work in two ways. There's the really, really technical work, and then there's public pressure. And our biggest wins have come at the moment when public pressure is really built up. What I've noticed over, especially maybe the last 10, 12 years, is that as more and more people get into this work, they get sucked into the technical vortex. And I don't think that's how we've gotten our biggest wins, like South Africa in '99 for HIV drugs, or getting the Indian patent law amended in 2005 to allow for more generic competition. I think our biggest wins have happened when communities and the global community at large have mobilized and made this an issue and brought that public pressure and heat. And so that would be my wish and my dream, is that we can really generate that kind of power going forward.
Absolutely, and that's what we're all here to learn how to do together, fortunately. So thank you. That's a really good grounding statement for all of us. So I see that Elizabeth in the Q&A box here is saying that there could be a comparison between patent abuse and medical malpractice, and that both of them are, potentially very damaging to patients and can harm people's health. She's wondering if that might be a kind of argument that you could hear at a congressional hearing in the future.
Yeah, I think that sounds powerful to me. I think that you should use that. I like it. I have been talking to a lot of people in the patent legal community behind the scenes who probably won't speak on this publicly, but they have urged me, as we do more talks for patent lawyers, and a lot of people who work in the patent system are just trying to get patents filed. They're not thinking about the policy issues. So as we try to bring this to them to say, hey, you're part of this big problem, they've really encouraged us to appeal to this ethical duty that lawyers have. And I think that's why your line here is just so powerful, because I think it appeals and makes that land in a different way.
Absolutely. So Jessica has another question, and it kind of comes back to what you had mentioned about standing being an important issue in court cases. And she's wondering if you know of any efforts, or if there may be any efforts in the works to take a test case to court in the way that other social movements have taken test cases to court.
Yeah, unfortunately, the history of this in the US does not give those of us maybe who are a little more jaded, it doesn't give us a lot of optimism, just because this has been tried, like I was saying, by the farmers, by the breast cancer patients, in other cases. So there's a level of defeat, I think, that some of us feel over time. But people in other countries have done this and won. Like the Lawyers Collective, who I used to work for, they brought a test case on this for TB patients, and they won in India. I think the US has standing itself is viewed differently here, like this idea that you have to be harmed. and what harm, I mean, it's just shocking, right? Like, why wouldn't a patient who couldn't afford a drug be harmed? But I think we can dig into this, and I think you all should form your own conclusions about how the law has worked out and go seek alternate legal opinions and see if you can, again, build the public pressure to make the conditions right that somebody would be willing to look at this differently. I think without the public momentum around a case, I don't think it'll, I don't think it will be successful.
Understood, but there's, always opportunities to continue pushing, as you said. So I see that Lori has a question wondering how the recent state price cap legislation, which is sponsored and supported by other diabetes organizations such as the American Diabetes Association, may factor into the broader patent issue that you've been talking about.
Yeah, it's an interesting question. I think that there are going to be challenges to price caps on this ground because it conflicts with the idea of monopoly powers through patents. I believe, if I'm not mistaken, the folks at Portal, Amit Sarpatwari and Aaron Kesselheim, I think that they've looked closely on this, and they actually have a presentation where they walk through how state and federal law in the US work out. So we can put that on the list of resources that I send you all.
Thank you so much. And I think we've got time for one more question here from Jen, who's asking how if standing only works with regard to having a commercial interest in an issue, such as wanting to take insulin, versus having a health interest in an issue. So for people with type 1 diabetes, that would be the harm caused by drug companies suing to prevent generic manufacturers from creating biosimilar insulins, for example. And she's wondering if that's been tested.
Yeah, that's what I'm referring to when I talk about the farmers and the breast cancer patients, although not specifically what you're raising here, but the same general principle is applicable. And I believe in the case of the farmers and Monsanto, the way the law is basically construed is you have to be at risk of being sued by the patent holder. So in that case, it was about farmers where if the seeds sprinkled over from the neighboring farm, this was a GMO case, and that farmer, were they infringing on Monsanto's patents? And so here the farmers were even able to say, yes, Monsanto's probably going to sue us. And then Monsanto, I think, put out a letter saying, oh, we're not going to sue them. And then the judge said, because they are not at imminent risk of being sued, they don't have standing. So there's just the way the courts interpret this is just so incredibly narrow. I think it is worth making this an issue, but I'm not sure how we're going to win it. And it's probably going to take some people with constitutional legal expertise in the US. And there are folks both at the ACLU, what was formerly the Public Patent Foundation, Dan Ravager, who I'm sure could sit down with you all and really walk you through the history of how this played out.
Absolutely. And there hasn't been a social movement in history that hasn't required some creativity and some outside the box thinking. So big, well-moneyed interests that are getting that money and power at their expense. So really, thank you so much for joining us. This was really, in a lot of respects, and we appreciate your time.
Thank you so much, Chile. Bye, everyone.
Bye. Since graduating college, she has worked in nonprofits, including as a case manager for seniors experiencing homelessness, as a criminal justice reporter, and now as the associate director of the U.S. Federation of the Sisters of St. Joseph. She coordinates collective justice responses for over 10,000 members. Kristen will be taking questions from the audience at the end of her presentation, so please feel free to enter your questions in the Q&A box, and Kristen will answer as many as our time allows. Kristen, take it away.
Hi, everyone. I am so excited to be with you and to be sharing about divestment campaigns. I'm just going to get this slideshow going for everyone. All right. So like Eli said, I am the chapter leader for Connecticut Insulin for All, and I've been living with diabetes for almost 15 years. My divestment work basically comes from my full-time job, which is working with religious sisters on justice movements and also working at their UN NGO in New York City. So I've been able to learn from a really great cohort, and I learn something new every day. And we've heard excellent presentations that have left me with a lot of my own questions about how to take action. So I'm really excited to present to you about divestment campaigns. And I'm going to come from an advocate standpoint, not from an economist viewpoint on this. So bear with me. I think everyone will be able to get this. I've broken it down, and it's more about how you can take some action items with a lot of this really great information we've been presented. So kind of the grounding topic to this conversation is questions we can all ask ourselves and should ask ourselves. As a consumer and as an activist, where do you spend your money? Where do you invest your time? And where do you invest your energy? And as an activist and a disabled activist, I'm constantly considering where I put my resources. We all have a finite amount of resources. And for me, this is why I was drawn to T1 International and the Insulin for All chapters initially. I wanted an organization that aligned with my values. And so I think it's important for each of us to think, why are we here? Why do we volunteer with T1 International? And why are we interested in the mission? And I think these questions are really great to ask ourselves, but we can start applying this to others. We can apply it to groups of people, to influencers, celebrities, colleges, universities, politicians, and even investors. And what if we held them to the same standards that we hold ourselves to? So let's get into what divestment actually is. And for the purpose of this presentation, we're going to define divestment as the withdrawal of investments or refusal to invest in companies or products that are deemed unethical. So that's a pretty broad term, and that's going to differ person to person, and it's also going to differ company to company. And that could mean the divestment of stocks, bonds, and other investments, but I also like to think of it as resources and time as well. Divestment is really one of many tools that activists have in their toolbox. We have protests, we have civil disobedience, which you'll hear a little bit tomorrow with Fran Quigley. And then there's also boycotts, which for obvious reasons, people with diabetes cannot do. We live and die by insulin, and it is so important that we acknowledge that as we move forward. And there's a large intersection between these different tools, so just to keep that in mind. What are effective divestment campaigns? So I've highlighted some of the sort of like top things I've seen in different divestment campaigns. And we'll talk about some specifics later. The first thing is really creating stigmatization of the offending company or industry. And the way that you've seen it happen is that people are deemed as sort of pariahs. And that is through effective media exposure and sharing stories like we do so well. And an effective and successful campaign, when you hear divestment, you think, okay, their stocks have to lower, there has to be a lower bottom line. But to be effective, it doesn't require that. There may be no impact on share prices, or you can have bad actors come in and snatch up these low stocks. But we have to acknowledge that people need these medications and these companies have to continue receiving funds. There's just no way around it. Even in a universal healthcare system, these companies will continue to have profits. But you can make it seem immoral to do business with them or until change is achieved, essentially. One thing that we do continuously well is utilize media exposure. We've seen it in just the thousands of Insulin for All articles that are run pretty much every year for the last couple of years now. And then wherever possible, effective divestment campaigns are a part of a bigger piece of the puzzle. So you bundle it with campaigns that have other direct effects, like I think of this fossil fuel energy boycotts, or you can have specific policy changes, which is something we are also already advocating for. And then the big major thing that I think we always need to keep in mind is, what are the solutions? So where do we reinvest our money? I think it's always important that we think about what communities are most directly impacted by the mountainous amounts of profit that these companies are making that Rosie talked about earlier. And how do we reinvest the money into these communities? I want to talk a little bit about divestment versus responsible investment. They share a lot of similarities, but there are two different approaches. And just to go over that, responsible investment is the practice of investing in socially conscious companies or using shareholder votes or resolutions to encourage better practices. Now, what is considered a socially conscious really depends, again, on the person and company. And then the shareholder resolutions, just for a little bit of an explanation, are when investors raise environmental, social, corporate issues of concern. And again, you'll see the similarities. They use PR and education to the public, and they're a way to garner attention from company executives. Now, when people and businesses are looking at responsible investing in companies, there's something called negative screens. And so negative screens for an investor is something that they will have no part in. So responsible investing is hoping to create change. But for a lot of organizations, again, looks very different, but there's usually a commonality. So tobacco, alcohol, arms, and weapons manufacturers are kind of considered the big three in terms of negative screens. What is really interesting about the negative screens, though, is that they're risky investments due to public opinion and politics around them. And they're generally due to successful divestment campaigns. And I left some questions about, what do people consider when they're considering divesting versus investing? And some of it is, how long have you been at the table? Are people listening when you're speaking? And if you're already an investor, would they notice if you left the table? So is it better to be a fly on the wall and have this information and feed it to others? Or would it create more attention to leave? And I think it can be a both and approach to activism. So I'm going to go over 3 campaigns that have made or are currently making a difference. There are plenty of more examples out there, and I encourage you, if this is something interesting, to do research on them. And additionally, this is really short overviews of the different campaigns. There's a lot of people and movements involved in making these campaigns successful, and I don't want to gloss over that. I can't talk about all of them. And just really honoring the historical movements of the past who have really brought us here. And we have so much to learn from Black communities, Latinx communities, communities of color, Indigenous folks, LGBTQ folks who have been doing the organizing around these issues for so long. So the first one is the South African apartheid, which was a political and social system in South Africa that enforced racial discrimination against non-whites from 1948 until about the early 1900s. And negotiations took even 4 years to reach, the political end of apartheid. Just acknowledging that these campaigns do take time. You'll see that there are so many different critical parts to this. And in 1962, the UN passed a resolution to create economic sanctions against South Africa for apartheid. And then all Western nations rejected that and then boycotted the entire committee together. It took another decade with something called the Sullivan Principles, which was a Black-led movement that essentially made it impossible for a lot of organizations to even do business in South Africa or produce parts. One of the commonalities you'll see through the 3 different campaigns we're going to talk about is that colleges and universities have been so critical to garnering attention. They've done everything from organized sit-ins, which you can see in this photo is from Smith College. I love it. Totally blocking the doors, making sure that classes were interrupted. Boycotts, some built shanty towns on campuses to just bring national attention to what was happening. And the first school to agree to divest their entire portfolio was Hampshire College in Massachusetts. But with that one, by 1988, a total of 155 colleges had at least partially divested from South Africa. One of the fun facts I love throwing out there is that President Barack Obama's first act of political activism was actually at Occidental College, organizing divestment campaigns around apartheid. So eventually, automotive and computer companies came along, and they refused to do business in South Africa as well. And because in part of these divestment campaigns, the US Congress actually overrode President Reagan's veto of the Comprehensive Anti-Apartheid Act of 1986 and successfully passed economic sanctions against the country. And a lot of people believe that that was kind of the beginning of the end of apartheid. But as you can see, this took decades and decades of work to reach there. It took a lot of organizers to get to that point. And you can see similar campaigns that have taken place in Sudan and the human rights violations occurring in Darfur and also in Syria and Iran. The next one is private prisons, and is a little bit more personal for me because the group that I work for, the U.S. Federation of the Sisters of St. Joseph, them and the many religious sisters that they work with were one of the primary organizations responsible for the withdrawal of Chase Bank from private prisons in 2019. That's all to say that this was also the lead-in for decades of activism, raising issues, investigations, and lawsuits happening in these private prisons. And at the time, before Chase had divested, they held 9% of US prison population, but 3/4 of immigrant detainees. And because of that particular issue, that is eventually how they were able to get Chase to divest. And then because of their divestment, 5 other banks followed. And as you can see, 72% of all current financing was represented by those 6 companies. It's a huge portion. Some of the major players in this divestment campaign, which obviously continues today, again, universities and colleges, teachers and public pensions, religious and faith communities and foundations have all been really core to that and have taken divestment efforts in their own lives. So you can see there's a lot of different organizations and ways to educate and divest. State legislators have also followed the lead, including working to pass legislation that would prohibit banks from financing private prisons. I just want to call attention to, again, some of the university and students that are working on this issue right now. So in 2019, Johns Hopkins students staged a month-long sit-in, and that was to cancel. They were trying to build a private police force on their campus, and also so that Johns Hopkins would end their contracts with ICE. Additionally, Harvard prison divestment campaigns, they have a just reinvestment fund. So instead of having their alum donate to Harvard, they are using those funds and redistributing them to communities that are most impacted by the prison industrial complex. I think the one that most of us will probably be pretty similar to, because this is very much a now issue and something that has garnered a lot of attention, at least this is what kind of like first put on my radar, was fossil fuels. And there are so many people working on this, and tons of celebrities that are working on this issue and talking about this issue. But again, colleges and universities, I think we have a lot to learn from college students and their tenacity. And so Swarthmore College essentially kicked off the nationwide movement. Universities and other organizations had been working in silos up until that point. And so after a portion of those students went to Appalachia and saw mountaintop removal mining, and that was kind of what led them to start this divestment campaign. And so it kind of interconnected colleges and universities across the US. And high school students are also getting involved, and they're using social media, sort of similar to how our Insulin for All campaign started. There's a lot of different ways to make this work. In 2019, at the Yale-Harvard game, which happened just down the road from where I actually live, I was actually in New Haven when this happened. It was pretty exciting news. So divestment protesters from both Yale and Harvard swarmed the field during halftime and refused to leave, and they just staged a sit-in for hours, and they were chanting "Disclose, divest, or this will be our death," and that went on for a long time and really brought a lot of attention to what was going on at the schools. Even in 2020, there's Divestment Day, and there was there was all these sit-ins and walkouts and banner drops, but also in addition to that is really looking about the communities that are most deeply impacted by the harm. So they really looked at the Indigenous communities and drawing attention to what's going on there. So we have an idea of what divestment actually is and some of the ways that different communities have engaged on the issue. But we need to talk a little bit about who do we actually divest from. And Rosie did a great job talking about the insulin manufacturers and how they are benefiting from the insulin prices, as well as the PBMs and the insurers. We know it's a complex system, that there's many people that are a part of this. So insulin manufacturers, of course, but who else? So PBMs, who are kind of the middlemen. We look at insurers, but also the executives and shareholders of all of these different circles that I have listed there, and how much money they are making by sitting on these boards, by sitting on as executives. We look at politicians. We know that politicians are making a ton of money in terms of campaign finances and what they're receiving. I have another slide right after this to highlight just how much money they're making yearly. We know diabetes companies and organizations are receiving a lot of money from the above aforementioned industries. And so they are also, we have noticed, especially when we talk about, say, the copay caps or about other legislative changes, because of that money, we have heard a lot of silence in terms of the deaths of people from rationing, and not even just the deaths, the total impact it has on people. And then colleges and universities. Colleges and universities receive a lot of money, whether it's from grants for, admittedly important research, but also there's endowments. So Lilly has something called Lilly Endowment, and they give out grants to communities, to, organizations that really deserve stuff, but also it could go to things like building part of the school and university. And when we look at Eli Lilly's shares, I think it's interesting that institutions own roughly 70% of those shares, while only 17% is public ownership. And I don't think the chat function's open, but we could talk about this a little bit more. But are there any others you can think to add to the list? These were the 6 main ones I could think of. There are plenty more. And this is just a slide to highlight how much money people are making, both from Eli Lilly and Sanofi. You can find this on opensecrets.org at any time. It's always a fascinating experience to go on there. And you can also see this is a bipartisan issue. The names at the top are all pretty popular names, regardless of their political affiliation. So definitely a bipartisan issue moving forward. So how can we incorporate this into our activism? I always like to be a little solution oriented. So at the beginning of this, I asked you, where do you invest your money? Where do you invest your time? And where do you invest your energy? Probably not a lot of time to think about it, but I hope, maybe after today's workshop or a week from now, you can kind of think about that. Now, we can ask ourselves this question, and I think this can dictate how we spend our time and our days. But I think we can and we should be asking these same questions of celebrities, influencers, politicians, companies that are benefiting from the sale of our lifeblood. Who is benefiting from this insulin prices? Who is benefiting from the big three? Who are shareholders in the big three? Have they shown they've been able to negotiate or listen to the concerns of shareholders or advocates? I have my personal feelings on that, but it's important to ask ourselves, are people listening? And I hope this presentation can leave you with some ideas or get the cogs turning about where we can move our activism collectively in the future. And then finally, I have this 4th question here that I didn't ask in the beginning, but this is a really important question. And, moving forward, where are we going to ask people to reinvest their money? Because we've already made gigantic strides in the stigmatization and in the media and PR circle. I think we can make huge strides in divestment. So let's plan for a future where we hold these companies accountable for our lives and hopefully start holding all pharmaceutical companies to these same standards. And so that concludes my presentation. I can take some questions. I also have my email. You can always find me at the Connecticut Insulin for All chapter. I'm always there, but also my personal email if you have any questions.
Thank you so much, Kristen. Unfortunately, I don't think we have time for questions right now, but we'll make sure that everyone has access to those emails so that they can reach out in the future. That was a really, really good look at, divestment campaigns over time, though, and how it can be an effective tactic for the Insulin for All movement. So thank you so much for your time and expertise.
Great, thanks.
Excellent. So speaking of flexing our power in different ways, we're going to close our day with a performance by Maria Isa and the launch of our digital demonstration. Maria is a national award-winning Puerto Rican singer, songwriter, actress, rapper, activist, and recording artist born in Minnesota and raised on St. Paul's West Side barrio. She's a recipient of the 2019-20 McKnight Artist Fellowship for Musicians, the CEO of Soto Rico Records. She directs mentorship for the nonprofit organization Twin Cities Mobile Jazz Project, and she's the co-host and founder of Latina Theory, a Spanglish podcast. Maria is an advisor for El Fondo Boricua, assisting disaster relief and cultural programming in Puerto Rico by way of Minnesota. She was diagnosed at the age of 16 with type 1 diabetes and advocates passionately for Insulin for All. Her latest EP, Amor Universal, is available now on all music streaming platforms. At the conclusion of her set, we ask that Insulin for All advocates flood social media with posts across all channels that are in line with the theme of the demonstration. People with type 1 diabetes have to make up to 180 extra decisions every day. We need pharmaceutical companies to make one. Lower the list price of insulin. The hashtags to use are Insulin for All, as always, and hashtag onedecision. For more information, you can go to www.t1international.com/digital demo. We'll make sure to put that link in the chat now. And if you've enjoyed the sessions today and you're looking for another way to support our work, you can visit www.t1international.com/donate to make a contribution, and we will also put that link in the chat. We appreciate everyone who joined us today and look forward to seeing you all again tomorrow at noon Eastern, 9 a.m. Pacific. Maria, thank you so much for joining us, and please take it away.
Thank you for this great, amazing day. It's an honor for me to be here amongst everyone who is passionate towards really making that change and speaking up about the change that needs to happen. We're gonna get started with one of my songs, but beforehand, I'd like to really dedicate these pieces of music in this time, in this space, to the lives that have been lost due to the fact that type 1 diabetics have rationed their insulin, and that we're here to say no mas, no more. People need to wake up. It's not just in our country, it's internationally. We need to unify our voices, unify our resistances for equity in all the injustices that are happening amongst the same umbrella. With that, RIP to Alex Smith, and so much thanks to the family, the Smith-Holt family, for fighting for our voices here in Minnesota. All of the families in Minnesota, but knowing that the work doesn't stop here in Minnesota, and that we hope that all the states will push forward in getting this Insulin Affordability Act passed. We're here, we got your back. We're the David and the Goliath. If we can do it, so can you. This first song is called By My Side, and I wrote it in this pandemic with my daughter by my side, and I fight living with this illness for so long, but excuse me, we're having technical difficulties right here. I'm DJing at the same time. I fight even more to have her by my side, and I'm here to be by her side amongst all of this. So really think about it while we're in our squares in a pandemic in this crazy world, that focus on what matters most. And that's love, that's life, that's passion, and that's your health. With that, let's kick it off with By My Side.
Don't let the cloudy days cover up your life. But you give the world shine so bright, brighter than the stars up in the sky. I just wanna do whatever's gonna make you smile, 'cause it can't go on forever. I promise we can make it better. As long as we're together, it'll be okay. It'll be alright. It'll be okay. Let's make it through the day. I don't wanna see you cry. I just wanna hold you tight. It'll be okay. It'll be alright. I just wanna live my best life with you by my side. You by my side. You by my side. When the goals seem too far away to reach, we're fighting for, baby, believe. We're awake right now, living the dream. I don't wanna lose your trust in me, 'cause it can't go on forever. Promise we can make it better. As long as we're together, it'll be okay. It'll be alright. It'll be okay. Let's make it through the day. I don't wanna see you cry. I just wanna hold you tight. It'll be okay. It'll be alright. I just wanna live my best life with you by my side. You by my side. You by my side. Yeah. You by my side.
Thank you. Yay, I see spirit fingers and hand claps in the Zoom. So much love, so much love. Like Eli introduced, I have had type 1 diabetes for 17 years. I was 16-year-old, junior year, impacted with the news that I was diagnosed with this. Thankfully caught it before I was in a severe coma, but it was told right and first and foremost that this is something we have to deal with for the rest of our lives, and that it takes us to manage with this little vial of insulin right here. And I remember how much the vial cost when I was 16, and I've seen and I have been there in a point in my life, being that college student off of your parents' insurance, really struggling, fighting to survive, and doing anything by any means necessary. And I recall when I went to Cuba back in 2016, invited to the country of Cuba to share my music and collaborate with other artists, I had a vial that was left out in the heat, and I was panicking. I had an extra one, but I was panicking that caught a little bit too much heat in my freezer pack. And something that was so scary and me crying, the Cuban people looked, and there happened to be doctors to say, "What is wrong?" And I said, I can't afford to get any more. And they were in shock, and they said, no, you have a prescription and we will get you, and that's okay. And I said, "How much?" And they're like, "Nothing." And I couldn't believe that. And that's the reality of healthcare. And that's the reality of why I'm fighting for social healthcare, because reality is that people didn't ask for money. They gave me what was needed for me to stay alive. And I was just applauding that and just so happy. And it's a story that I shared with policymakers here when we were fighting legislation, sharing that story that my life valued, no matter what my citizenship was, no matter where I was in the world, it valued that here's the medicine for it, and this is what will help you stay alive. And there was no price tag to it. So I only dream about that. And amongst this pandemic, it's really brought us a lot closer together to recognize what we have to keep fighting and how to utilize technology and not letting that world shut down, that we have to keep being an advocate for those voices who may not be eager to speak or don't know how, but if we do, and we utilize our platforms as doctors or rappers and singers and musicians, families and advocates of our family members or children, do what it takes, because you're saving lives 1 minute at a time. This song that I'm going to do is in Spanish, and I dedicate it to the Cubanos and all of the Boricuas and all the Latinx folks that specifically battle with this. But just know I'm with you, voy contigo. And the song was written amongst the pandemic too, because my concert, my tour to Latin America was canceled, which was connecting me with a lot of type 1 Latinos around Latin America. And although it was canceled, we're still able to utilize the medicine of what music is to me. Music has kept me alive, has kept me going in those days where even if I did have insulin, the stress and the impact of the mental challenges is real just as much as the physical. And music is my outlet. And this is what has kept me going and provides for me just as much as my insulin. So with that, I may not be able to touch those Latin American countries, but I physically in this tour because of this pandemic, but I'm here with you virtually. And this song is called Voy Contigo. And I'm gonna close this piece with that. Gracias. Le, 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 le. Le, 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 le. Feel free to clap at home or dance. Rumba para bailar, rumba para gozar, rumba para bailar, rumba para gozar. Me enamoré la primera vez que te conocí. Amorcito, cómo me haces sentir. Que en esta vida se tiene que vivir feliz. Y eso sin ti no hay. No, eso sin ti no hay. Yo me voy contigo, porque nada más me importa cuando estoy contigo. No, calentamos la noche, candela, me voy contigo. Pa' otro mundo en la luna llena contigo. Me voy contigo, sí, contigo, sí, contigo. Voy contigo para Cuba, voy contigo para Santo Domingo, voy contigo para Panamá, voy contigo para México lindo, voy contigo para Honduras, voy contigo para Guatemala, voy contigo para Argentina, voy contigo para Costa Rica, voy contigo para Venezuela, voy contigo para El Salvador, voy contigo para Colombia, Perú, Chile y Ecuador. Voy contigo para Paraguay, Bolivia, voy contigo para Uruguay. Voy contigo a mi Borinquen, Puerto Rico, el mundo entero. Yo me voy, yo me voy, yo me voy. Porque nada más me importa, no. Yo me voy contigo, la luna llena contigo. Me voy contigo, sí, contigo, sí, contigo. Hasta el mundo, la luna llena contigo. Me voy contigo, sí, contigo, sí, contigo. Gracias. Peace, love, thank you. Type 1 International. Adelante. Gracias.
Gracias y a usted, a tú. Lo siento, mi español es muy malo.
Sounds good to me.
We appreciate it. And thank you so much for that really, really excellent performance, Maria. That was a wonderful way to close out today. Thank you to all of us for joining us for the first day of this year's Insulin for All workshop. Please make sure to check out the links that Al put in the chat box for the digital demonstration and the donation link. And we look forward to seeing all of you tomorrow. Have a really great rest of your afternoon or evening.